And this is our MS Warriors to kick off this event. And it is an 8-minute video. So enjoy it. And
I'm Mindy Eisenberg,
we'll begin right
and my
after.
story began as the daughter of a mother with the most debilitating form of progressive MS. All of my experiences, including being a healthcare administrator, a yoga student, teacher, and therapist, brought me to the formation of Yoga Moves MS and being able to offer the gift of yoga to those impacted by MS. I am proud of the mighty Yoga Moves MS community that we have created, including our students, their families and support network, our teachers and volunteers. We all come together with a common bond to improve the quality of life for those impacted by MS. We practice yoga and we expand our knowledge about holistic health and wellness. Together, we transform challenges to triumphs. I view our community as a tapestry of interwoven stories that change lives and expand our world. When members of the Yoga Moves MS community share their stories, our connections deepen. From our Yoga Moves MS tapestry, I present to you 3 special inspiring individuals who will share their story with you: George, Stacy, and Marcia. Each of their stories is unique, but they share a common bond of resilience and hope. Let them grab your attention, engage your imagination, and open your belief to a world full of possibilities. Please join the Yoga Moves MS community and share your story with us.
My name is George Athanasopoulos. I'm 54 years old. I used to play in a competitive men's baseball league. I was diagnosed at the age of 33.
My name is Stacy Hirsch. I'm studying at the University of Michigan. I'm studying movement science in the School of Kinesiology on a pre-med track. I was diagnosed when I was a freshman in high school in November of 2016.
My name is Marcia Williams. I have had MS for 24 years. I was diagnosed in '98. In 1997, let's take it back, I had just got married. That was the hardest time of my life.
I was at work and I started having numbness on the left side of my face, tingling and numbness. And I thought it was a dental problem. And it was a Friday. I'm like, now I have to wait until Monday to go to the dentist, you know.
I got numbness on my full right side of my body, from my mid-torso all the way down to my foot, extending to my arm. I was completely numb.
It started with my eyes, and I couldn't see. It was like double vision, blurry vision. So I went and got my eyes checked, and they told me, you need to go and see a neurologist, and they didn't tell me why. I never understood that.
So we went to the ER. They kept me overnight. They ran tests. They checked out, my carotid artery. The next morning, a neurologist came in and he gave me some tests, and it's almost like he knew. Then 2 months later, I was diagnosed.
I went to a neurologist who sent me to a more specialized neurologist who sent me to another more specialized neurologist. And then finally, after a few rounds of MRIs and a lumbar puncture, they were able to diagnose me.
I can email her. Do you
They
have
ran
her
a lot
email?
of tests. They says, well, maybe you have lupus. We think it's lupus.
Here, I'm gonna email you.
We think it's demyelination disease. Never at all did anybody say anything about multiple sclerosis. So did some more testing. The doctor says, well, we have good news, we have bad news. Well, what's the good news? Well, you don't have a lupus, you don't have demyelination, but you have MS.
I can no longer work. I need my forearm crutches and my walker. I don't drive because I have the foot drop.
I had a teenager in school, a new husband, no job because of MS. So what do I do?
I used to go to these dinners a lot to where the drug companies would host and the neurologists would talk. And a neurologist named Dr. Voci, I remember this so vividly. Dr. Voci's talking, I'm talking to my friends, I'm enjoying my food, and he said something about yoga. And it crossed my mind, I'm like, yeah, yoga, right, that's cute, you know. I used to play baseball, I used to play football, I'm like I'm gonna do yoga, I'm like, you know. So he said, if you want, after the event's over, I have these flyers here to pick up. So, you know, I didn't think nothing of it. We're getting ready to go. My wife says, are you gonna go get a flyer? She goes, you should go get a flyer. And I know when my wife says something, I better listen to her.
When I took a class, and after the class, I just felt so relieved, so relaxed. My pains were like barely there. I felt like at that moment, I never even had MS.
And I remember going in there meeting so many wonderful people, but the way it made me feel. I mean, I had more energy. I actually, at that time I walked with a cane. I felt better walking out, as far as the way my legs felt, more energized than I did going in. All right, I'll try it a second time too. And then I went the following week, I felt the same way. And I got to meet so many wonderful people. I was joking around, I said, you know what, it was kind of cool because for about 10, 12 ladies, I was the only guy there.
Everyone has different coping mechanisms, whether that be journaling or sitting and watching TV or going on a walk. Me and my friends really like to do walks. It's a little bit of exercise. You can talk and catch up with people while going on the walk. I eat healthy. I cook for myself.
One day, my teacher said to me, you could be a good yoga teacher, which I didn't think I could. It felt good because I used to work in the medical field. I used to help people. And I'm kind of still in the medical field because I consider myself still to be helping people. It felt really good. And I wanted to have more of that feeling. So I said, I've got to keep doing yoga.
For 6 years, I was going to Red Lotus doing yoga, practicing it. Now I still practice it at home 4 or 5 days a week.
When I was getting diagnosed with MS, there wasn't a lot of resources for pediatrics with MS. I want to be a pediatric neurologist and be able to help people.
I love Yoga Moves MS community because it's a support group for me.
The peers and the people, the friends, that we all deal with the same issues that we have in life.
When you're applying to med school, they always ask, like, why do you want to do this? Why do you want to go into medicine? And for me, like, it's very specific. This is why I want to go into medicine and help people.
People that I met in my life are just unbelievable. I have so many lifelong friends and so many great, wonderful people. And because of that, I know I'm a better person.
I'm not different. I'm the same as every other junior in college.
I would never go to another yoga class ever because nothing like Yoga Moves MS. I don't think I lost anything. I think I gained like more of a family.
Wow. Thank you for coming on today. We're sorry that we started a little bit late here, and I know people are still coming on. Little zap snafu, but now we're ready to get going. And I hope you enjoyed that video. For those of you who saw it, for those of you who did not, we will be showing it again and we will send it out. It will be available. I'm so proud of our warriors, our resilient, inspiring warriors that were in that video. I'm so proud of our Yoga Moves MS community. We're so connected and strengthen each other. In each of our stories, they're woven with this golden thread. Together, we create this tapestry of life. So I want to say how thrilled I am by the response from today's event. Over almost 1,000 people are registered to this event. We will be sharing such amazing information from our speakers. Let's take a moment to just breathe Take an inhale through your nose and an exhale through your nose. I know I need to calm my nervous system. So welcome to this virtual holistic health and wellness forum for MS. For those of you who are not familiar with Yoga Moves MS, we are a nonprofit that has provided daily adaptive yoga, mindfulness, and meditation online and in person for over 18 years. Education about holistic health and wellness programs are an important component of the Yoga Moves MS mission. The translation or the meaning of yoga is one, and it refers to the whole person. Hence, holistic health care and self-care. Today, our primary focus is to provide education to empower our mighty, mighty community with knowledge from leaders in the MS community. We are fortunate to have this opportunity to learn how we all can envision and contribute to our own wellness. The hope for our learning today is that we can tap into the depths and the layers of our innate resilience. The information provided by our presenters, specialists, and leaders will help us to do just that. This is the yes moment to imagine and create this vision and then live it with support of our Yoga Moves MS family. Just a few housekeeping items. You're going to be glued to the screen with our top-notch speakers, no doubt. Make sure to move during breaks. There's going to be great prizes to win in the raffle throughout the day. The prizes for you to choose will include some videos that can be practiced on your seat, in the chair, on your mat, and on your feet. Our new yoga wheelchair series. The winner must be live in the event or in person in the event to give us their email to claim the prize. Watch for a direct message in the chat to you, the winner. We also have a few surprise prizes as well. Use the Q&A on your screen for questions. Please keep the content of the questions related to the speakers' presentations and refrain from questions that apply to more of a personal or private nature. Please do use the Q&A to tell us where you are from. We want to know where you're from, where we're touching as we're all connected together. Ask questions, use the Q&A. The chat feature will be for technical issues, which I hope we don't have any more of, and we will communicate with you directly through that for the prizes. Come and go as your schedule allows. You will be notified via email when the recordings of the speakers will be available in the virtual exhibit hall in approximately a week. So if you haven't visited the virtual exhibit hall, you must, you absolutely must. I want to say namaste to our event planning committee. It takes a village to put this together. It takes months and lots of time and thought. Thank you to Gina Beach, Laureen Branch, Marnie Sharon, Lindsay Dems, Catherine McRae, Leah Narens, Lori Olson, Beth Stone, and Lori Svensson. Thank you so much. Really, I feel it in my heart, and I hope you do too. Please touch your heart with your hand and feel it. Thank you to our 3 resilient warriors on the video, George, Stacy, and Marcia. A huge namaste to our sponsors who are integral to making this event possible. Make sure to visit them in the exhibit hall. Namaste to our top sponsor, Genentech. Thank you for your continued support of Yoga Moves MS, your commitment to neurology and particularly to MS patients and the science of MS. Much gratitude to Biogen and Bristol Myers Squibb. Namaste to Horizon, Janssen, a subsidiary of Johnson & Johnson, Novartis, Sanofi, TG Therapeutics, the MIND, the Michigan Institute for Neurological Disorders, local to here. Thank you to our exhibitors and partners who helped to spread the word and support this unique event. Alexion, Banner, EMD Serono, iCompanion, Sun Communities, Huntington Bank, MS Views and News, and Overcoming MS. We are all connected We Are Community. This event is sure to be stellar because of our sponsors and our partners' support. Each of our speakers and their organizations are on the exhibit hall. Make sure to visit the exhibit hall as you will want to learn more about their impressive bios, accomplishments, and backgrounds. Two special individuals will be introducing our speakers, Dr. Martin Belkin, I'm losing my voice here. Dr. Martin Belkin from the Michigan Institute of Neurological Disorders. We are so lucky that he is in our own backyard. He's the medical director of the Mind, which one is the largest MS centers in the country. And Dr. Voci, who used to be here and is now in Chicago and works for Amita Health. Both Dr. Belkin and Dr. Voci are on our board, and Dr. Voci has been our chair since 2014. Thank you, Dr. Voci. I hope you heard George mention you in the video. So without further ado, let's begin with our amazing presenters. I'm so excited to introduce Betsy Hartman to you. And Betsy's gonna come on. Hello, Betsy.
Hello, thank you so much for having me. Can you hear me okay?
I absolutely can hear you. So let me just introduce you briefly before, although your bio is amazing. I'll read fast. You must go to the virtual exhibit hall to learn about Betsy. So Betsy is a board certified music therapist. She's a neurologic music therapist fellow. She's going to present on music therapy for MS, how music plays a role in the 3 levels of wellness for people living with MS and their caregivers. She will provide an overview of music therapy, including education, training, recent research, and the role of music therapists, speaking specifically to the music therapy program at the MS Center at the Swedish Neuroscience Institute. If time permits, she will lead an experiential exercise to showcase how music therapy addresses physical and psychosocial health. I want to mention that our keynote, so Betsy's starting us off and Dr. Bowen will be concluding with the keynote, and they are both from the Swedish Neuroscience Institute. I feel so fortunate and lucky that they are with us today. Betsy is a board certified music therapist and has extensive experience working with people living with cancer, MS, and their families. She founded PNW Music Therapy in 2014, and since that time has partnered with the Swedish Medical Group to build and lead its flagship music therapy program at the Swedish Cancer Institute and Swedish MS Center. Betsy is passionate about developing tools and resources to help reduce pain and anxiety, improve coping skills and wellness, and enhance motor, speech, and cognitive health. In addition to her clinical work, she partners with companies to develop resources, tools, and content which improve access to and awareness of music therapy. Betsy participated in developing the award-winning music therapy resource, MS in Harmony, The Power of Music as Therapy Video, and is a guest speaker for podcasts such as MS Journeys on iHeartRadio and Real Talk MS. Thank you so much, Betsy, for being here. I love your beautiful smile, and I can't wait to hear you.
Oh, thank you, Mindy, and hello, everyone. I'm so thrilled to be here. I might have included something that there might be an experiential in this talk. There is definitely going to be an experiential. I cannot help myself but to offer music to everyone today. So music is coming for you, and we're just going to start off with that right now. Let me pull up my screen and share this with you. One moment, please. All right. Make that bigger. All right. Can we all see that? Mindy, I can see you, so maybe give me a thumbs up to make sure you're seeing that screen okay.
Yep, we got it.
Beautiful. All right. My name is Betsy Hartman. I am a board certified music therapist specializing in neurologic music therapy, and I want to start our time off with some music today. You're welcome to join me wherever you're at, sitting or standing. You can close your eyes, you can watch me play. I always like to check to make sure that sound is coming in okay. Beautiful. You should be hearing harp music right now. Take a minute to find your breath, breathing in through your nose and out. In music therapy, I talk a lot about rhythm. The rhythm of the seasons, the rhythm of our body, our breath, our thoughts. Our rhythms are always changing. And everything around us can affect our rhythm. Our health affects our rhythm, our relationships, our work. As we move into this time together today, I invite you to pay attention to your rhythm. What is your rhythm right now in this moment? I think we have the rhythm of our body. We have the rhythm of our mind and the rhythm of our heart. Can you add some descriptive words? Maybe even you find your own rhythm and beat today. The rhythm of our body might be feeling energized, maybe it feels fatigued. Our mind can often feel like it's racing and zooming around. You might notice that your rhythm is already changing as you pause and listen to music. Find your rhythm today. And as you zero in on what your rhythm is right now in this moment, ask yourself, what do I need to do with my rhythm today? Am I acknowledging my rhythm? Am I accepting it? Do I need to shift my rhythm? Do I need to change things a little bit, perhaps so that you can be open to receive all this amazing content information today? Or are you nurturing your rhythm? Are you helping it to grow, helping it to flourish? What are you doing with your rhythm today? The beautiful thing about rhythm is that rhythm is never good or bad. Rhythm just is. It exists on this continuum. The sound of rhythm, tempo, and pace, it's not good or bad. The best gift we can give ourselves is to acknowledge what our rhythm is so that we know what to do with it. What is music therapy? It is evidence-based music intervention supporting individualized clinical goals within the therapeutic relationship of a board-certified music therapist. You can come back to this space if you haven't already, taking a deep breath. Briefly, what does it mean to be a music therapist? Well, music therapists need to attend an approved university program, receiving a minimum of a bachelor's degree in music therapy. From there, we move on to complete 1,200 hours at an approved internship site. After that, you're eligible to sit for a national certification exam. If you pass that exam and maintain your credentials in a 5-year cycle, you are eligible to hold, use, and maintain the music therapist board certified credentials. Those are the credentials that I have, with also a specialty in neurologic music therapy. Music therapists work in a variety of places too: hospitals, private practice, mental health, schools, all over the place. How can music therapy benefit people with MS? The primary goals that we're working on: supporting the physical, emotional, cognitive, verbal, and social challenges and side effects of living with MS. We do that by using evidence-based music interventions. There's two components to music therapy, an active and receptive component. You all just had the opportunity to experience the receptive part of music therapy, one of it at least, one of the parts. Listening to music. How can you listen to music, whether it's being offered to you live or through pre-recorded music, like listening to a playlist on your phone in the environment around you? That's receptive music. The other piece of music therapy is active music, engaging and actually playing instruments. And I just have to share, in order to participate in music therapy, no background, confidence, or experience is required in music making. Just like if you were to go see a physical therapist, they wouldn't say, oh, are you a professional athlete? Do you have any skills in movement? No, that wouldn't happen at all. And that's just like music therapy. In order to participate in music therapy, you don't need to have any background, confidence, or experience in music making. Music therapists are trained to come to you, assess your needs, your goals, talk with you about what you have going on and what do you need support with. After we determine that, then we move into a plan to help support and address those goals. And the way that we do that is through music, through active music making or receptive music. That is what music therapy is. Let me tell you a little bit about some of the goals that we might address here. Oh, my slides aren't turning for me. There we go. Oh gosh, but before I do that, I have to share this with you. This is a rewrite of a song from India Ari's song, I Am Light. And this song was rewritten by a group of people living with MS and their caregivers. And we wrote this together through a weekly music and wellness group that I facilitate. And these are the lyrics that are sung to the tune, I Am Light by India Ari. And I just want to read some of this to you. This is what the group wrote together. I am love, I am hope. I am not what MS has made of me. I am not the broken parts in my nerves. I'm not the pieces of what I have become. I am strength. I am resilient. I'm not the wheelchair that I'm in, nor the walker that I may be using. I'm not the crutches that hold me up. I am here. This is who I am. I am human. Hear me roar. Hear me cry. Hear me laugh. I am human. Hear me roar. I am not the shoulds that I was told. I'm grateful I can grow old. I am not my speed. I am not my pace. I am not my enemy. All might, all might, all might. I am all of me still on the inside. Again, those lyrics were written by a group of people living with MS. I encourage you to check out this song, I Am Light. It's a beautiful song, and maybe even venture on your own to rewrite the lyrics. Make the lyrics yours. Tell your story of what it's like to be affected by MS, living with MS, loving someone with MS. The therapeutic process that you engage when you allow yourself to creatively think like that is incredible. And this is what comes out of it. Let's see if I can get my slides to turn again. There we go. Therapeutic goals: motor and physical, emotional, mental health, cognitive, speech and language, social. Some of the things that we do in a music therapy session when I'm working with people with MS, we work on gait training, fine and gross motor skills, speech and language skills, pain management, coping, managing stress and anxiety, memory recall, using music to help improve attention, sustain attention, help with focused attention, alternating attention. We also use music therapy to help improve speech and language skills. If you've ever been in a choir, you know that what you do is work on oral motor or respiratory skills. You're breathing, you're working on enunciation, volume control, pitch control. These techniques, when put in the neurologic music therapy umbrella, are able to help support therapeutic goals of speaking. Also, social skills, social goals, working together to be with people. Every week when we come together in my music and wellness group, we're connecting in a way that is truly heartfelt and meaningful. I want to talk with you just about what some of this might look like and the music therapy interventions that are actually used to accomplish some of these goals. Well, how do you use music to improve gait? How does that help me? How do you use music to help with anxiety and stress management? Or how can you use music to improve memory? So I'm going to run through a mini session, just super fast. It's going to be turbo speed. This is something that's typically done over a 60 or 90 minute time period, and we're going to do it in like 1 or 2 minutes here. I want you to check back in with your rhythm. At the beginning of our time together, I invited you to find your rhythm. And take a minute again, wherever you're at. This is something you can do anytime, and I want to show you how. Is just finding your internal rhythm. I like to use my chest, my heart as my drum beat. Just finding that beat, finding your breath. Maybe you even notice that you start tapping your foot, or maybe you start swaying your body. And play a rhythm that feels good to you. You might find that you need something a little bit faster. You want to pick up your energy, boost your mood. So maybe you need to live in this rhythm a little bit. You might find that you're moving a little bit slower. Wherever your rhythm is today, just acknowledge that. Acknowledge what you need. I want to offer you a little bit of music. Inviting you to breathe with me, moving that breath deeply into your diaphragm, practicing expanding your rib cage. So when you're ready, let all of your air out. Then prepare to breathe in, 2, 3, 4, and out, 2, 3. Just a couple breaths in. 2, 3, 4, out, 2, 3, 4, and in, out, 2, 3, 4, breathe in. This time hold at the top and hold, 2, 3, 4, breathing out, 2, 3, 4, and hold, 2, 3, 4, breathe in, 2, 3, 4, and hold, 2, 3, 4, and release, 2, 3, 4, breathing everything out, allowing your breath to return to normal. We might engage in some exercises to work on some articulation, things like you can try that with me at home. No one has to watch you do that like y'all just saw me do it. Loosening up your body, understanding what this part of your muscles feels like in your face through simple vocal exercises that you would do in a choir. We work on that in our groups to help people improve articulation, volume, pitch control, breath support. Do you know, or have you ever had the experience of sitting at a restaurant or in a public space and all of a sudden you notice that you're tapping your foot? And then you realize, I'm tapping my foot. Oh, I'm listening to music. I didn't even realize there is music playing. Whenever we have a direct auditory input, we have a direct motor output. Your subconscious in that scenario heard the music. And not only did it hear the music, but your body had a physical response to it. Your body was moving to the beat without your mind consciously being aware of that. That is what we use in music therapy. We use things such as rhythmic auditory stimulation, a tempo, a beat, a pulse to help your body move. If you have any experience with gait irregularity, shuffling your feet, spasticity, left side, right side weakness, oftentimes when I work with patients, I see the way that their body moves and it can be stiff, it's irregular, it's unpredictable, it's uncontrollable. The moment we add rhythmic auditory stimulation, that completely changes. I see a rhythmic pattern of walking, symmetry, I see confidence, I see body posture improve. Your body is having a direct response to the beat, and that's just by listening to something like a metronome. Imagine then when we add music, when we add instrumentation, or when we add a song that someone loves, a song that makes you feel good, that makes you feel strong or empowered, everything changes and people are able to just move their bodies in ways that they can't normally because their mind isn't allowing them to. But the music steps in and acts as this bridge to bridge the gap of that communication, to help that gait pattern, that walking pattern improve and move in a way that they want to. Cognition. We don't have time to run through this exercise today, but I'm going to tell you about it right now because this is something that you can do at home on your own. So listen up. Play a song, any song. This is how you're going to improve your ability to sustain focus or alternate focus. Play a song, any song, and pick out one instrument in that song. So let's just say there's a piano. And as you listen to the piano, challenge yourself to only listen to the piano throughout the entire length of that song. See if you can do it. What's going to happen, depending upon the song, of course, but what's likely going to happen is other instruments are going to start becoming a part of that song, and it's going to pull your attention away from the piano. But challenge yourself to listen only to the piano. Focus in on that for 3-5 minutes, however long the song is. That exercise, that simple exercise, is helping you improve your ability to sustain attention. What about to shift or alter your attention? Pick 2 instruments and practice shifting your attention back and forth between those 2 instruments throughout the entire song. Really simple, something you can do every day, something that literally every single person can benefit from. How does music improve mental health? Well, we have a lot of ways that we can engage listening to music and playing music to help manage our anxiety and our stress. One of the ways that I love working with people is by teaching them how to play an instrument. And the beautiful part about working with a music therapist when it comes to learning how to play an instrument is that we're not here to have a specific musical outcome. We're not trying to make you a famous musician, rock star. We're here to help mental health, to help build connection, to help improve physical health, those clinical therapeutic goals. So we call instrument playing therapeutic instrument performance. How does sitting down, learning how to play an ukulele lift your mood? How does it improve your fine motor skills? How does it help distract you from a loop of anxiety that you might have in your brain? How does it help you connect with your partner, your friends, your children, your grandchildren? That's what we're looking for. It's not about being the best ukulele player. It's about bringing something into your life that improves your mental health, your emotional health. I already talked a little bit about how you can start using music therapy today, active music listening to improve that memory, recall, and focus. Create a therapeutic playlist. Is it difficult for you to wake up in the morning? Make a playlist that boosts your mood. What does that sound like to you? Is it hard for you to fall asleep at night? Make a playlist that helps relax you. Soothing, slow, repetitive tones. I talked about instrument playing too. Are you looking for ways to express your emotions or even just get in touch with your emotions? Buy a drum. Start playing that drum. If you're mad, let that anger out on the drum. If you're happy, Practice expressing and sharing that emotion on the drum. Believe me, it can be incredibly therapeutic to just sit and play a drum, hashing out a conversation, letting out those emotions. And then by the time you need to actually share those emotions with someone else in the world, you've had the opportunity to process them yourself. All right, I'm coming to the end of my time today. I've included here some research, just amazing work that's going on. What is rhythmic auditory cueing stimulation doing? How is neurologic music therapy helping people living with MS? More and more research is out there to just prove that music is powerful. Music makes a difference. The fundamental components, rhythm, melody, pitch, make a difference in how our body, our mind, and our heart are healing every day. So that's all that I have for you. Thank you so much for allowing me to be here today. I've included some resources, some interesting sites about music therapy in the US, music therapy throughout the world, and other information that you can pull from there. But thank you. Thank you.
Thank you so much, Betsy. I am amazed by how much overlaps with yoga and
Yes.
breathing and some of the exercises that you talked about.
Yes.
Really, really beautiful. I want to try the exercise that you gave us instructions for. Are there any questions in the Q&A for Betsy? Thank you, Betsy. I see from Mandy, this is wonderful. Any recommendations for artists that we can find on Spotify to use for therapeutic music? Great question, Mandy.
Great question. And this might not be the answer you want to hear, but I'm turning it back to you. It is all about your preferences. Thinking about what do you like, what makes you tick, what makes you happy, what makes you maybe sit in your sadness, whatever it is that you need. It's so individualized. What I can tell you are start listening to those fundamental components, the rhythm. We know that slow, repetitive music is going to help us relax because our body entrains to that tempo. Our heart rate decreases, our respiratory rate decreases. So if you're looking to use music to relax, think about slow, repetitive sounds that aren't super interesting, so they're not stimulating your mind or your body. That's one tip I can give you. Otherwise, you kind of have to do the research yourself.
Thank you. Next question is there an online music therapy program?
Online music therapy program. I don't necessarily know about a program. I would direct you to MS in Harmony, which is what Mindy mentioned at the beginning of this time. That is an online resource that is compiled of several music therapists who have put together music therapy informed interventions in a virtual format that you can check out. I don't even know how many interventions, I guess, are on there now, but it's all based off of, like I teach, body, mind, and heart. The interventions are organized in that category. So I would look at starting there.
I want to take with you, Betsy.
If you want to take with me, we do have our weekly virtual music and wellness group that happens every Wednesday afternoon.
We'll be sure to make sure that people know about that. Who
Thank
are
you.
watching on today, all our 970 registrants, which I hope they will find their way on, and the recording is going to be available at Betsy. One other question, is it covered by insurance? Is music therapy covered by insurance?
Yes, it is covered by insurance. You have to check with your insurance provider, obviously, but we are addressing physical goals, just like physical therapist or occupational therapist or speech and language therapist. So oftentimes the goals that we cover can be billed under that category.
Yay. Well, I'm happy to hear that. We're still working on that for yoga therapy, Betsy.
I know.
It's time. So Yanni or Janie, I'm not sure if I'm saying this right, so please don't take it wrong, but I'm so happy you're on from the UK.
Yeah.
And are there any research
Yes.
studies being undertaken with the UK that we can get involved in? I'm from London. Welcome, London. We're so happy you are on.
Welcome from London. I do not know of any specific research studies that are happening right now in the UK. I would direct you to check out the Academy for Neurologic Music Therapy. They're currently based in Canada, but are a worldwide organization. They do a lot of international work. And that would be where I'd recommend that you start looking.
Someone asked, do you have any recordings?
I do not have any recordings that I release and sell to the public. Maybe that's something I need to do.
Yeah, I think you got to put that on your to-do list.
Right. I think I need to.
Someone asked if you could repeat the site, but then they listed it for you. So
There
you're
it
good
is.
there. It was msinharmony.com, which is a wonderful site. You must check it out. All right. And so last comment was your music was so soothing. Oh, we already got, she wants your recordings. You got work to do, Betsy. Isn't it snowing there? You know, have a little snow day.
Yep. I think I'm going to have a recording snowing day today.
Thank you so much. Thank you so much. And you're going to hear from Dr. Bowen later in the day as we hear more that's coming from the Swedish Neuroscience Institute.
Yeah. Thank you.
Thank you so much, Betsy, for sharing your time and knowledge. All right, Dr. Voci, Chair of Yoga Moves MS, is going to introduce Dr. Cody. Dr. Cody.
Oh, sorry, a little technical issue there. Thank you.
That's the theme of today, I think.
Par for the course, yes.
We're hoping that people got the new email with a new link. If you know anybody who was trying to get on today, you might want to let them know there was a new link that was sent out through Yoga Moves MS and Eventbrite.
Great. Well,
Okay.
thank you, Mindy. I have the honor of introducing our next speaker, Dr. Jeannie Cody. She is a lifelong resident of Michigan, completing her undergraduate studies at Michigan State University in nutritional sciences. She then went on to medical school at Wayne State and then her neurology residency at the University of Michigan, where she was chief resident. She stayed on in the fellowship there in multiple sclerosis and neuroimmunology, and then spent several years there on staff with the faculty attending for the care of MS patients at their MS center. She then transitioned to the Memorial Healthcare Institute for neuroscience and multiple sclerosis at Owasso, Michigan in 2019. She has specialty interest in pregnancy planning, prenatal and postnatal care for women with MS, as well as an interest in lifestyle and weight management as it relates to neurologic disorders. She also holds certification in medical acupuncture. So Dr. Cody will discuss the benefits of acupuncture for MS. Dr. Cody, we thank you for your involvement in our community today. Thank you.
Hi, can you guys hear me okay?
We can hear you.
Okay, excellent. And then can I have my slides brought up? I think someone was going to open them for me. Or at least give me control of a screen. Perfect. And is there a way to give me control? I trust other people to be techie more than I trust myself.
Sorry, Dr. Cody, I can give you control. I'm just trying to get the display.
Yeah, no problem.
There we go.
Thank you.
Yeah. Okay. So on the, oh, there we go. Dr. Cody, on the top bar or on
Mhm.
your screen where you see the green share button, there you go.
Did I
Thank
do it
you.
right? Yes.
Yep, you're all
Okay.
set. Thank you.
Thank you. So let me just make sure if I click through, I'm good. Perfect. Okay. So, yeah, I am super excited to be here today. So thank you for having me. And I am happy to talk about this topic. So after my training ended, I was sort of like, what do I do next? Am I just supposed to work every day? And I thought, well, what else can I learn? And at the time at U of M, we had this wonderful acupuncturist neurologist. And I thought, well, gosh, that's really interesting. I spent some time with him and asked U of M if they would support my pursuit of getting certified in this. And so they said, sure. And that really started my path down learning more about acupuncture and how to incorporate that into practice. So hopefully this will give some good information. Betsy is a tough act to follow. I loved Betsy's lecture. I'm so excited to incorporate music therapy to this, but maybe this will kind of perk some interest in people as well. So we'll start with just what is acupuncture, and it depends a little bit on who you ask. So there are sort of 3 schools of thought, and the first one I pulled from wikipedia.com. And they say it's a pseudoscience, and the theories and practices are not based on scientific knowledge, and it's characterized as quackery. So that is sort of one school of thought. And I think I can see that sometimes with patients when they come in to ask about acupuncture, and you can tell they're very nervous, like, am I going to roll my eyes or yell or be upset or, dismiss that as a sincere question. I think the more traditional way we think about it as being part of the practice of traditional Chinese medicine. And the idea with this school of thought is that the body has thousands of acupuncture points, and they're connected in these pathways or meridians. And they're all named differently, and they travel in different directions, head to toe and toe up. And there's sort of these maps. And the idea is that you have qi, or this energy that's always flowing through your body in ways that should be balanced, and that contributes to health. And that if the flow of energy is blocked, then you can have health issues, pain, immobility, other disease. And that acupuncture manipulates the flow of qi, which is the QI. Qi to stimulate healing and to rebalance and to prevent and protect and heal from disease. And then the sort of third way is taking modern day scientists and saying, well, how do we really understand what is happening? Maybe it isn't totally nonsense because it has been a practice that's existed for millennia, but maybe it's not quite as simple as redirection of qi. And is there more of a biochemical or electrophysiologic basis for what's happening? And so in nowadays times, there's many studies that are really trying to answer this question and looking at a response in the body through a variety of means. And some of the working theories is by manipulating the tissues, by inserting these needles through the skin into different points in the body, can you change blood flow? And in doing so, can that promote healing? Can you cause micro tears or micro trauma that will then stimulate your body to heal and heal beyond the micro trauma to the area of damage? So we think about that sometimes with dry needling, when patients have really thick muscle knots or muscle spasms, just directly putting some needles right into that to let go. And that's sort of encouraging that muscle release along with that. And then there's also a lot of studies right now looking at laboratory changes. So a whole variety of different chemical messengers in the body, and really looking to say, if we stimulate at certain points, can we measure changes with these different cellular kind of chemical signalers? And is that what's happening when patients experience benefit from acupuncture? And I always just think it's nice to know the history of kind of where things came from. I spend a lot of time with my MS patients talking about the history of MS and sort of how it's evolved diagnostically, therapeutically, what we know about natural history studies of MS. And I think if you know the longitudinal history, one is just really interesting, and it really gives you a good foundation of knowing where you've been and helping to understand where you need to go forward to understand or evolve something better. So briefly, this originated in China, and there are textbooks dating back to 100 BC and called the Yellow Emperor's Classic of Internal Medicine. And that's really a compendium of a lot of different kind of educational bits of knowledge that were passed down and compiled into a book. And you can actually get it on Amazon. So I put the Amazon link to that. And then the next sort of major book, and this is used in a lot of naturopathic schools and acupuncture schools as part of their literature or curriculum. And that's the Great Compendium of Acupuncture and Moxibustion. And that came out 1300 to 1600 AD. So a long time ago. So that just really, I think, speaks to how far back this practice dates. And at that point, there were 365 points used that were intended to modify the flow of qi. And by the 1950s, we actually had acupuncture institutes that were being established in China to teach this practice. In the US, it started to first be mentioned in literature in the 1800s, and there was a flurry of interest in 1972. And around this time, the Nixon effect, what had happened was while traveling with a journalist, the journalist got sick and needed surgery, and they were able to use or provide anesthesia through acupuncture. And I think that really kind of raised some interest as to the value of what acupuncture could bring. By 1996, the needles used for acupuncture were no longer considered experimental. And then by 1997, the NIH gave its first consensus affirming effectiveness for a limited range of conditions. And that really has not been updated since the last time I checked. I think it's pausing for a moment. There we go. And so what they had said is that there are promising results that have emerged showing efficacy of acupuncture for adult postoperative and chemo, nausea, vomiting, postoperative dental pain. It could have roles in addiction, stroke rehab, headaches, cramps, muscle pain, arthritis, and that there may be value in incorporating acupuncture in the treatment of these conditions. The World Health Organization also lists indications for acupuncture, and I won't read all of this to you, but it does sort of run the gamut from, sinusitis to headaches to other areas of pain as some of the conditions that there may be value in incorporating this into treatment. So as far as what we think we know, there was a nice review that was done. This was done earlier this year, and this group, this was published in the MS and Related Disorders Journal. If you want to take a look at it, it's free to read. But in essence, what they did is they went through PubMed. And this is where we keep a lot of our literature that's searchable if you're trying to learn a lot about a topic of what's been published about it. And you can search by terms. And so they put in acupuncture and MS and pulled every piece of literature up until about 6 or 7 months before they published, so September of 2021. And it ultimately pulled up 75 articles. 31 they included in their review, and to be included, they wanted a full text in English. They didn't want a reduplication. And so some of the studies or some of the reduplicated articles sort of didn't get incorporated, but at the end of it, they had 6 articles commenting on prevalence, 5 randomized controlled trials, one of which was a crossover, some animal data, some non-controlled studies, some case reports, and a case series. And they took this and tried to compile it in a way to say, collectively, do these show benefit and in what way? And one of the studies in that 31 is one that I pulled out because I do think this is one that is something that I might found valuable in the care of my own patients. So this was a very small study, 14 women, and it combined group acupuncture with group sessions about health promotion. So this was sort of both the actual treatment, but then also some educational and instructive lessons, just really focusing on health overall. And this was called the Integrating Acupuncture Within a Wellness Intervention for Women with MS. And this was just a small way of looking at that. But ultimately, the people reported that there was less self-report of fatigue, less stress, pain, depression, anxiety, and sleep interference. And part of my world, part of my job is choosing the right medications to help patients be successful. But then there's this whole host of symptoms that still need managed, and we don't always have great treatment. So anything that is, relatively safe and may have some value, no matter how conventional or unconventional it seems, I think we have to take all of these really serious and pull together whatever we can to create that perfect treatment plan individualized to each patient. So this one, I thought, this one just really spoke to me. What they also saw was more health promoting behaviors, self-efficacy for health promotion, better social functioning, and quality of life was increased. And ultimately, at the end of the day, that's what we're trying to achieve for all of our patients, but in a way that is safe and responsible. So the other things that review of those 31 articles pulled out, or their consensus statement said that acupuncture, traditional and scalp, may improve some of the symptoms of MS. And in particular, they were more apt to see some sort of documented influence over fatigue, pain, gait impairments, and bladder dysfunction. So when you see statements showing the value of acupuncture, a lot of those statements will reference back to these articles and to this review in total. So one way that we use acupuncture, in a sense, is through nerve stimulation for overactive bladder. So one of the acupuncture points, SP6, is in the lower part of the leg on the inside above the ankle. And that is one of the points that you would consider stimulating if you were trying to treat bladder symptoms. And interestingly, we will do posterior tibial nerve stimulation, accessing that point. And in essence, you're stimulating that nerve, and we would consider that electroacupuncture. And you're using that to carry a message to talk to the pelvic nerves, the sacral nerves, with the idea of it can decrease overactive bladder. So from the standpoint of, is acupuncture quackery? I think this is interesting because you might not think about this, but in essence, this is acupuncture that we are performing, for patients to help a symptom. And there is some data to back this up. And I actually have a lot of patients who do utilize this through consult with our urologists. So as far as what to expect, so in a traditional appointment setting, because there's going to be acupuncturist clinics and then medical acupuncture, and there's slight differences between these. But what to expect in a traditional experience is you'll give a history, you'll be examined, and the acupuncturist will decide through their questioning and their physical exam what the appropriate treatment would be. And that may involve not just, a traditional bedside exam, but they may look carefully at the face and the tongue, and they may palpate more different areas looking for some of the tender spots. And there's also some pulse or heart rate evaluation that can go into that as well. And then the types of treatments, needle insertion, I think, is what most people think about when you think about acupuncture. Moxibustion is another practice that sometimes is utilized, and that involves burning dried herbs on the body, not damaging them, but placing that collection and burning the top in different locations as part of a traditional Chinese practice of medicine. Medical acupuncture is a little bit different. So it's sort of an adapted version of traditional Chinese medicine. And some will come in with a medical diagnosis and we'll say, okay, well, based on this diagnosis, this is what we think we need to do to treat that symptom. So frequency is really based on what you're trying to treat. So in theory, some would say the longer the symptom has been there, you may need more sessions of treatment to start to see more response. Others might be well treated in a session or two. And as far as what to expect, so when I perform acupuncture in clinic, I do ask patients to dress in comfortable clothes because I never know where I'm going to need to put the needle. So I need to be able to get anywhere. So like tight leggings, no thank you. You know, loosey, blousey gaucho pants or a skirt or, sweat clothes or something that's easy to move around. Avoid an empty stomach. So you do want a little bit of food in there just so you have some nice nutrients to keep you going for the day. And you want to be well hydrated. Some medications may be held the morning of, and that really more relates to pain medicine, with the thought being you don't want to mess with that sort of opioid system if what you're trying to do is manipulate, some of those types of receptors. So if someone's on an aspirin or an anticoagulant, generally I don't need to worry about them taking that day. These needles are so tiny. Bleeding is really usually not problematic if you're careful with where you put the needles. So patients will either be seated or they'll lay on a table. We'll clean the skin and then we'll place the needles. And those may be pricked in for a split second. With pediatric acupuncture, often it's just a single poke and the needle comes out right away. You're not going to leave the needle in the kid. That could be just sort of distressing and just tricky if they're wiggly. In an adult, though, you may be able to leave it in longer, anywhere from a few minutes up to 10, 20 minutes. Some people may do longer than that. Usually I'm about a 15 to 20 minute for most cases. And then you may apply electrical stimulation to that. We call that electroacupuncture. So that is a picture of me on the left when people were practicing placing their needles. And where you'll see is 2 teeny tiny needles in my back and 2 teeny tiny needles in the backs of my knees. And that's one of the formulas that we use for treating low back pain. And then the picture on the right is not my hands and feet. I do not have that nice of toenails. But that is a colleague of mine who is showing some of the different placements of needles in the hands and feet that we'll sometimes perform. And so what might you feel? It can be a brief pinprick. You might feel nothing at all. And what I'm looking for is if people can feel we call it the daiqi. So it could be an aching pain. It might be a zip or a tingle. It might be at a different depth. So it takes a little bit of manipulating to try to find that feeling you're hunting for. And sometimes the muscle might spasm around the needle and it feels a little tight. After acupuncture, some people might feel a little drained or tired. Some people might feel really energetic. Soreness or bruising, perhaps, but these needles are so tiny, that's really usually not a typical symptom. Muscle twitches and spasms often, and sometimes people can just really feel an emotional release. They might cry after. Serious side effects are really uncommon. In theory, could a needle break? Sure. It's made of a material that makes that very unlikely. It's got wonderful flexibility. Bleeding, again, these needles are so tiny that's unlikely. Infection, they're sterile, single use, unlikely to occur. Passing out, some people are very needle phobic. So in those cases, I do ask them to lay down. And again, why you should hydrate and eat before you do it. And then puncture a vital structure. So if you don't know what you're doing and you stick a needle in a person, things can happen. If you're trained and you know anatomy, then you should have the knowledge to not have that be an issue. And so that's a picture of the needle. The needle is actually that tiny little gray piece of metal attached to the pink tip. It's so thin and flexible, it has to be housed in a plastic casing, because if you tried to poke the needle in by itself, it is so thin, it would just bend and be all loose. So you use that as a plastic guide to help keep the needle straight while you're inserting. And that just speaks to how tiny it is. So this is, if you think about an 18 gauge, that's a IV for like giving you fluids. This is equivalent to, you could put 5 acupuncture needles to equal 1 18 gauge. That is how teeny tiny they are. We talked about bleeding, usually not an issue. Infection, usually not an issue. And then syncope, listen to the patient. If they're feeling dizzy or lightheaded, I'll have them lay down or put their feet up. And usually people are most nervous the first time in the first poke, and then they see how easy it is and they're like, oh, that's not bad at all. So if someone does ever feel like they're going to pass out or they're prone to lightheadedness, I did include a couple fun acupressure points that you can try at home. So GV26 stands for governing vessels, and that's one of those meridians or pathways in the body. And it's that point right under the nose. So if you ever feel like you're drowsy or you need to wake up or you're going to pass out, that's a good spot that you can try to apply firm pressure for a few minutes to see if that can be alerting. And so that is a picture of the meridians to give you a sense of, from a traditional Chinese medicine standpoint, where the points are sort of allotted throughout the body. And so they're running really in different directions up and down based on the actual named channel. So for nausea and vomiting, you'll often hear about a spot on your hand. So from an acupuncture standpoint, it's called pericardium 6, and C-bands take advantage of this. And so that C-band that you wear for nausea or seasickness pushes right where acupressure pericardium 6 will be. And so to find that, you're basically going down from your middle finger about 3 finger breaths. And that's going to be that spot where you can apply kind of a rolling pressure to try to help with nausea and vomiting naturally. I think another one that I use more often if I'm going to be performing acupuncture is large intestine 4 or LI4. And the thought with this is this area here is called a command point. There's a few command points where, like, if someone has a problem, you are getting those areas no matter what. And this is the command point for face and head. So for any face or head disorders, you'll find an acupuncturist will needle this area. It can also promote contractions. So in theory, you would not use this point in pregnancy. And the way to find it is you'll take the crease of one thumb, put it on the webbing of another thumb, and just roll it up. And where your kind of nail digs into, that's LI4. And that's the spot where you can apply pressure to try to treat a headache. And then another one I always like to do for fun in the office is ST36. So this spot is thought to have immune boosting properties. So every flu season, I'll walk around and offer this to anybody that wants to have it done. And the way to find this is you'll grip underneath your knee. It'll be your 4 fingers. So measurement is really proportional to your body, not the person needling you. So your 4 fingers, and kind of right under where that pinky will be, right outside the shin bone, is ST36, where you'll be able to stimulate or provide pressure for immune function. So how to find someone? The NCCAOM is a good place to look for someone who will have gone through certifications and be registered at a statewide level. So they've taken all of those steps to have a licensed practice. Most big hospitals will have someone who offers acupuncture services. You may find it in private practice clinics as well. The training is different for a physician than for a non-physician. So there's a variety of ways to sort of locate someone. But ultimately, I think the end goal is the same, which is to really promote wellness. So as far as someone an ideal candidate, I love treating MS with disease-modifying therapies when that is appropriate. I never pretend that acupuncture is a replacement for a disease-modifying therapy. I very much view this as complementary, not an alternate. So, part of it is the right treatment for your MS through disease-modifying therapy in most cases. And then what else can we do to complement that to really just improve wellness. So, for me, there are times where I recommend it as an add-on, but not a replacement in most cases. And the idea is really incorporating all of these interventions to improve wellness and outcomes. So does insurance cover this? It depends. Actually, the Medicare Part B does cover up to 12 visits in 3 months for low back pain. And if there is documentation that people are responding, it'll cover an additional 8 sessions. So, for some insurances, for the right indications, there is access to this. And so these are some of the other plans that have some coverage. It's going to be plan specific, and you'll just have to reach out to your insurance to see. I went a little bit over on time, so I apologize, but that was the bulk of what I wanted to share. Are there any questions for me?
There are. So there were a few about how do they find a medical acupuncturist?
Yeah, so really, if you're looking in your area, I would start by looking at the largest healthcare centers first. So that would be the academic hospitals or the larger healthcare systems. They should have a search function that would let you look for that. Outside of that, it's really going to be probably word of mouth, or if someone has self-advertised. If they are a medical doctor performing acupuncture, there is about a 200-hour certification process that people have to go through. So, if they are listing that service, they should be able to tell you where they trained, when they trained, and how often they practice. But I think just like any person providing a service, there's going to be more than one way to approach it. And part of it is making sure that you connect with the person providing the care.
All right. A question about, I get scalp acupuncture and usually get relief of symptoms, but sometimes the MS symptoms get worse. There's a theory that the symptoms may need to come out that way, but I can get confused at that point about whether I'm doing the right thing or should take a break. Could you speak to this?
My recommendations are always going to be tailored on a case-by-case basis. I will say that paradoxical reactions are not uncommon treating any health condition, where sometimes, you expect A to lead to B, and once in a while you get a C. I think for me, it's really looking at the overall trajectory. Historically, has it had value and this was a weird blip? I would probably stay the course. If it was really more than one time not the right fit, then I would say maybe it's time to change up the formula, because there's many places to stimulate and many thought processes about how to achieve some sort of desired outcome. So maybe I'd give it 1 chance or 2 chances, but if it was really not leading to overall wellness, I wouldn't hesitate to mix it up.
That's a great answer. Does it help pain?
So I think it is on a case-by-case basis. I had this case of a young woman. She did not have MS, but she was in the ER probably every couple of weeks for pain medication, and had declined walking, like did not want to walk, wanted to sit, and was in the ER constantly for pain medicine. And I'm like, let's try this. Let's see what we can do. We started doing sessions for back pain, and I kept her out of the ER for like a year. So I can't say that is, a response everybody's going to have, but in her individual case, we were able to keep her out of the ER, away from receiving, strong pain medications, and keep her up and ambulatory. And, I haven't always had that outcome with everybody, but that was one where I thought like this was really valuable for her.
Thank you. One other question, what's an MDT?
Oh, DMT. Sorry.
Oh, they said DMT. Okay.
I shouldn't have said that. Okay. DMT, disease
Well,
modifying
this
therapy.
happens. Things come out of our mouth sometimes.
Yeah. You're always supposed to say it and then put the letters, and then you can use the letters. So that was like presentation faux pas. So disease modifying therapies, or DMTs. So that is what we call the MS medicines, like the injections, the pills, the infusions. It's a quick way to reference MS drug treatments.
Great question here. Which symptoms of MS have you seen with the best results with acupuncture, such as spasticity?
So initially I learned it for spasticity. That was the symptom I was trying to crack initially, when I'm like, let's go pick up this skill set. Probably though, I've seen better benefit with non-spastic pain syndromes. So headaches, back pain, neck aches, and then some fatigue is probably where I've seen the most influence over symptoms. If someone has true significant severe spasticity, I might be going more the Botox or baclofen pump route or some other route before I would turn to acupuncture. So it's really a case by case basis though.
Last question, what's the difference between acupuncture versus dry needling for muscle pain and tightness? Which one seems to be beneficial for MS or disc disease pain?
So dry needling, you're putting it right where the muscle spasms are. So someone who's trained will palpate, figure out the directions and the bands of muscles involved, and then stimulate right in those muscle bellies themselves to get them to just sort of let go. So if someone says massage feels so good, but it doesn't last, that's where I like to bring in dry needling because you're getting deeper into those muscle fibers. With acupuncture, you may be stimulating nowhere near that area. So you may say that there's a point in the foot that has influence over neck pain. So we'll stimulate far away from that site. So it's, again, really tailored to the patient. If they're saying like this muscle kills me, then I'm like, let's just stick a needle in it. Whether that's, you consider that dry needling or acupuncture. But mostly the major difference is dry needling will only be in the muscles involved. Acupuncture may be more widespread in the body.
Thank you so much, Dr. Cody, for
No problem. Sorry, there's a
your
window behind me.
wisdom and time today on your Saturday. And I know that I always enjoy acupuncture. It's just a great, like you're feeling off balance, just somehow there's something about it that just makes me feel more balanced after it. It's usually a really good nap too.
Yes, patients often feel wonderful when I come in. I keep the lights low. I might have music on, and then we take it out and it's like, it was like a nice rest for sure.
Thank you so much. Thank you so much. Thank you everybody for your questions. And you have a wonderful day, Dr. Cody.
Bye, everybody.
I worked so hard to get Dr. Cody on. I asked her for a few years, will you please come speak about acupuncture? Please, please, please.
Happy to help.
Yeah. We finally got her on.
Okay.
So thank you so much. It's not often you find a neurologist who's also an acupuncturist. At least I don't think it's that common. Our next speaker, I am absolutely thrilled to introduce to you. We're going to kind of breeze through our breaks and just to get back on track since we started a little bit late. But that doesn't mean you shouldn't move. In fact, our next speaker is going to talk to you about movement. And so without further ado, I want to introduce you to Mariska. We're so honored to have her here today. There she is. I took her training earlier this year, and she's a wealth of knowledge. I don't know where she learns everything she does, but there's so much she knows about. So you're in for a real treat. Let me just tell you a little bit about Mariska Breland. She's a certified Pilates teacher for MS. She created the Neuro Studio. In 1999, Mariska took her first Pilates class. After a 2002 diagnosis of MS, she became a devoted yoga and Pilates practitioner and taught her first class a year later. You didn't waste any time, did you?
Not really.
She then founded Fuse Pilates, a contemporary Pilates method and studio based in Washington, D.C., for which she developed all of the group classes and training programs. She's also an inventor of the patented Fuse ladder. And I think I need to go do some of that music therapy. That might help. Mariska completed a research project on Pilates from MS patients as part of her comprehensive Pilates certification through Body Arts and Science International. She later expanded that research into an in-depth, multi-day Pilates for neurological conditions teacher training course and incorporated the latest research in neuroplasticity and neurorehabilitation into a program designed for people with MS, stroke, Parkinson's disease, and other neurological conditions. This year, as if that's not enough, she launched the MS Master Plan, the most comprehensive single source for MS patients in existence, covering over 275 videos, including interviews with experts and patients about everything from diet and exercise to understanding how MRIs work and how to read the results from successful strategies for disability and workplace claims to the psychological ramifications of an MS life. As a student of medical neuroscience, Mariska has also designed workshops to focus on how to integrate brain science into exercise programs to enhance performance and improve neurological function. Take it away, Mariska, and I'm so excited to hear your journey with MS as well as your presentation today.
Thank you so much. I'm so glad to be here. And also, she gave such a long and in-depth introduction that I don't feel like I have to do much of one. But my presentation today will include some of my journey and sort of, I'm sure a lot of people who are in this presentation paying attention are going to see some things that they recognize in their own journey. So on that, I'm going to share my screen. I'll pop in and out of it, but let's go ahead. Always takes a minute to get these things started. Okay. So today I want to talk about understanding mobility. So basically understanding movement. Mobility also goes a little bit into our understanding of flexibility and sort of how we get tight and how it becomes hard to move. And what I hope by the end of this is that you have some different ways to think about why movement in multiple sclerosis can be limited and things that you can do to make it better. So first thing, most important thing to know is that our brains are very, very smart, even when they're doing things that annoy the living hell out of us. Your brain is only going to allow you the amount of mobility that it feels safe, which means that things like spasticity, things like problems moving that we have a lot in MS are not necessarily bad things, even though they might feel very bad to us. So what makes it hard to move in the world of multiple sclerosis? There's lots of different things that can affect it. And a lot of times, and this is kind of where I started my journey in trying to figure things out, we address the area of concern. A lot of doctors say, you have foot drop, so let's look at the foot. Let's look at all of the things about the foot. And then it doesn't actually work. Sometimes the thing that actually improves what you need to work on isn't the thing that's the problem. The previous speaker was talking about acupuncture and talking about sometimes addressing the neck. You might be doing something in the foot. It's not that different from how I would look at things in terms of the body. I wouldn't look at just the foot. I would look at the entire system. So foot drop. Foot drop was not my diagnosing symptom, but it was my second big flare-up. And it's the thing that to this day, sort of foot drop and spasticity are the things that I deal with the most in terms of having 20 plus years of MS, like what's actually affected me. So some of the issues in terms of foot drop and getting your foot to lift when it doesn't want to lift is that one, your foot is really, really, really far away from your brain. So things that are far away from our brain tend to have the most problems when it comes to neurological diseases, because there's a lot of neural pathways that have to be traveled to get from your brain to that muscle. So the muscle that lifts your foot is called the tibialis anterior. It's a teeny tiny little muscle far away from the brain. Another thing, which also kind of plays a role in foot drop a lot of times, is muscle spasticity. So muscle spasticity is a tightness that is reserved for us with neurological conditions. So you only get muscle spasticity if you have damage to the brain or spinal cord. And spasticity is actually a protective reflex against the stretch reflex, which they test when they like hit your knee with that little hammer. They're testing the stretch reflex. And when you have an overactive stretch reflex or a stretch reflex that won't turn off, you develop spasticity, which is this tightness of muscles that we experience. Now, we also experience regular person muscle tightness. So regular person muscle tightness is something that anybody can experience. And that would be like if you sit too long, if you have bad posture, muscles get tight. Tightness is still a protective thing. For instance, right now I have a rotator cuff tear that has nothing to do with MS at all. It has to do with me trying to stop something from falling by reaching back behind me and tearing a tiny muscle in my shoulder. And so now I can't lift my arm all the way up to the ceiling because it hurts. So that's another thing that can protect from moving is if you have pain. So a lot of times in the world of multiple sclerosis, we have pain. Oftentimes that pain is from inactivity or it's from moving incorrectly. And some of that incorrect movement is because of muscle spasticity or tightness or foot drop or things like that. Balance problems are other things that we deal with that affect mobility in a negative way. In terms of balance, there are 3 neurological components about that. So your visual system, your vestibular or inner ear, and also your proprioception. Your proprioceptors kind of tell you how your body is leaning. So we have a lot of proprioceptors in our feet, for instance, but you have them all throughout your body. They're sensors in your skin, muscle, and tendons. And so if we can locate the source of the balance problem, whether it's neurological, like is it because you are dizzy all the time because you have a vestibular issue, or is it because you can't feel your feet and that's affecting proprioception? That would change how we might address that to improve your mobility. Is it musculoskeletal? So if you have really tight calf muscles, for instance, because of spasticity, that can affect your balance. Or often in the neurological world, it's a combination of those things. And then also when people have sensory issues, so there's sort of a lack of connection and you have a perceived instability because you can't feel something, or you feel things incorrectly. So if you have a lot of loss of proprioception in your hips, you might lean more to one side, and you don't think you're leaning to one side, you think you're standing evenly in both feet. But that sensory disconnect can be something that can make it more likely that you would fall or that you would have movement problems. So as you can see, there's lots and lots of places where things can go wrong that negatively affect how you move. Now, in terms of my story, I had what a lot of people in the relapsing remitting MS that I'm probably in secondary progressive, who really knows? I don't know how they can definitively tell you that, but I've had MS for 20 years and that's kind of a long time. So in 2003, so I was diagnosed in 2002, but shortly afterwards, I ended up with foot drop. So I went out drinking, doing shots with friends one night, last time in my life I've ever done shots. And I woke up the next day and my foot was literally kind of floppy. And I also I couldn't feel my left hand. And it was the worst flare-up I had to that date. And I couldn't really walk for about 6 weeks. So roughly the time that most flare-ups last. So it was like 6 weeks. And then things kind of started getting better. But I very, very, very likely had residual weakness in lifting my foot. But like most of the time, and people have early MS, I felt like all of my issues had resolved. Like I felt like I'm walking normally again. I could wear flip-flops, which I haven't worn in years, but I felt like walking wasn't really a problem. But I had some sort of residual weakness. Now, at some point, I developed spasticity first in my calf. And I didn't really realize I had spasticity until I was on a trip. I was actually in Prague. And if you've ever been there, they have like the cobblestone streets. And I was wearing heeled shoes, which you can't really wear on cobblestone streets. So I went and bought a pair of flat shoes. And I was just catching the ball of my foot on all these rocks all the time. And then I noticed that my calf was really tight. It just felt tight. So at some point I was developing spasticity. It wasn't until 2008, so we're talking 5 years post foot drop, that my ankles started to hurt. So first visit to a doctor, which at this point was a podiatrist, to say that my ankle was hurting. So his thing was, doing orthotics and whatever, which didn't really help much. But I was walking less. And then as I was walking less, the muscle spasticity was getting worse because I was using my ankle less. It was getting weaker. So at some point, roughly around 2011, I could not actually lift my foot up. Physical therapists could not get my foot to lift up because I had something called an ankle contracture, which I still have to this day, which is something where you get so much tightness around the joint that the joint doesn't want to move. So I can't lift my foot more than, like, if I can stand flat on my feet, but I can't lift my foot up from standing flat on my feet. And so then, because I was really hard to walk, I was walking less, and then I was getting more weakness, and so forth and so on. So less walking, more spasticity, less walking, more spasticity, less walking, more weakness, more spasticity, more weakness, less walking. So it was just sort of this cycle that was really hard to beat. And I ended up going to, trying lots of things to try to fix this foot drop, ankle contracture, spasticity issue. And at no point working on foot drop did my walking get better from working on the thing that I thought was the thing. So foot drop is one of the most common causes of gait or walking problems. And walking problems in neurological conditions are compensations that we use to get around a foot that does not move properly. So for me, I tried stretching. I stretched. I would sit in front of the TV with one of those stretch bands, and I would fold forward, and I would stretch, and I would stretch, and I would stretch, and I would stand on the edge of stairs, and I would stretch. I would do yoga classes and stretch, and nothing worked. And then I did round 1, 2, 3 of Botox. I did myoblock, Botox, and Dysport. So I covered the whole range of Botox options with serial casting. So serial casting is where you have, I didn't do a cast, but I did a brace where they increased the amount of stretch on my foot consistently over weeks. Well, I also have neuropathic pain or nerve pain in my foot. So I would end up ripping the cast off in the middle of the night because my foot would hurt too much. But at no point did I actually get more range of motion. I just actually felt weaker when I tried to walk, which is actually a common thing. And one of the reasons why I don't actually like what I would consider overstretching for foot drop or calf spasticity, because it does increase weakness in your calf, which actually makes walking harder. And then I was doing exercise, which helped some, but when I was exercising my foot, I wasn't really getting much better at walking, or if I was getting improvements at walking, they weren't sticking. So one thing that's important to know is that it is going to be really hard to move if we aren't stable somewhere else. So if I wanted to, for instance, lift my foot off the floor, and I'm going to show you guys this in a little bit, but if I wanted to lift my foot off of the floor, I need to be able to balance on my opposite leg. If I don't have stability in my opposite leg, it's going to be impossible to lift my foot up. So you start to go up the chain of the body. So we're looking at the foot, we're going up, and we're seeing, like, where else is there weakness? Where else could there be potential to get better movement? So where we see weakness often are first the glutes and hamstrings. So your butt, the back of your legs. And when you're walking, you really need to have strength in these muscles, or also when you're standing and balancing, to be able to push your leg behind you to get forward momentum. So walking is almost sort of similar to swimming, where you would have your arm reach forward to push you back. Your leg reaches forward, and then your leg ideally pushes back behind you to give you forward momentum. So to have that, you need to have strength in the back of your legs. You also need to have strength in your quadriceps, which is the front of your legs. These are common areas for spasticity, and this is actually where you see a lot of problems in terms of falling. So if you don't have the ability to bend your knees kind of slowly to sit down, or bend your knees sufficiently to sit down, you kind of kerplunk down, or you might fall to a seat, which has a high risk of falling, which is not ideal. But coming from standing to sitting is actually one of the probably top 3 ways people with MS end up falling. A very, very big deal are the hip stabilizing muscles. So the hip stabilizing muscles are your upper outer butt, and then your outer thighs. So your upper outer butt muscle is called your glute medius, and that is designed to keep your hips level and then to move your pelvis as you're walking. And if you don't have strength there, your balance is probably going to be pretty bad, and your walking is probably going to be pretty bad. So when you see people with foot drop, a lot of the times you're going to see hip weakness as a very big factor in how somebody is walking. And that's sort of our main demonstration thing for today. And then also the upper body. So it's not just the lower body that's the problem when we have walking issues. The forgotten part of the body that a lot of times tends to be the bigger issue is the upper body. So if you are unable to hold your posture upright because you have weak core muscles, which would include your abdominals and also your back muscles, then you're basically falling forward when you're walking. It's going to be harder to lift your feet up because your weight is in the wrong position to lift them up. And we also use our arms when we're walking. So when people don't use their arms at all, that can also become an issue. So there are connections that go all the way through your body. So when you take a step, so let's say this guy with the arrows on him is taking a step with his right foot. So let's say he's weighted his right foot. So his weight is on his right foot. There's a force that goes up through your body. So it goes up your leg. It crosses through something called the posterior sling. So it crosses from your glute through, fancy term, something called the thoracolumbar fascia. So the fascia, which is an area where you get the knots in your muscles, that goes from your right side through your lower back on your left, up to your left shoulder, down through your left arm. So when we walk, when we're stepping forward with our right leg, ideally we're swinging our left arm forward at the same time. And that's sort of the way that force should be traveling through your body. This is also something that happens called a central pattern generator, which is a reflex that is a spinal reflex that when you walk should be kind of turning on. And walking is actually something that is a reflexive action, which is why for most of us who have muscle spasticity or foot drop or something like that, it's hardest to walk when you start walking after you've been sitting for a long time, or if you even have to start walking after you've been standing for a long time, because that reflex has ended up turning off and we need to turn it back on. And then for the force to travel correctly, you need to have strength and stability in all of the major joints. And we're going to say, especially the ones closest to the core, the center of your body, which would be your hip and your shoulder. So the way the connections work is it's shoulder to opposite hip, knee to opposite elbow, and wrist to opposite ankle. This is a lot easier to see when we think about quadrupedal animals, so like a dog or something. So when a dog is walking and they're in a quadruped, so they have 4 legs instead of arms and legs. So when they go forward with their right paw, their left paw also goes forward. So their shoulder of the right side is connected to the hip of the left side. The elbow, I consider that my dog has elbows, especially when she sits on me and sticks her elbow into my body in some way. The elbow to opposite knee and the wrist to opposite ankle. So that's kind of how the connections go. So let's say you have foot drop on your left foot. That's connecting all the way up to your opposite wrist in terms of how that force kind of goes through your body. So I know I'm going through this kind of fast, but that's because I want to have time to answer your questions. So in terms of finding stability for better mobility, I wanted to show you a couple of different things, and then I will answer your questions. So I'm going to switch over, or Mindy, maybe you can do it. Can you switch over to my other camera? Let's see, how do I do that? Can I pin it?
I think so. Sorry, Mariska.
It's currently blacked out, which I did not do.
Is it?
It also says Mariska Breland.
Okay. What happens if we switch to gallery? So the camera is blacked out. Is the video open on it? Is the video functioning on it?
Yeah. Actually, not showing up, but let me.
Are you logged in on the device?
I am, but let
Okay.
me, let's try this. It says I cannot start my video because the host has disabled it.
Huh. That might have been the one that I turned off because it was still running. So hang on 1 second.
Yep.
I thought it was your main video that I disabled. So I apologize. Let me see if I can get you back.
I'm going to look in the chat in the meantime and see if I can see any questions. Questions that don't.
There is a question about the site that you launched.
Okay, so my site is theneurostudio.com. So it is all exercise that is, it's basically like a workout site completely targeted to people with neurological diseases, divided up by symptoms. So you can look for exercises for foot drop, for balance, for spasticity, for bladder bowel issues, like literally anything that is a common neurological symptom, we have exercises for it. And then the MS master plan is also on there, and that has, well, it's 27 hours of content, but it's all divided in like little 3 to 20-minute videos. That's on there. And we do have like free trials for the NeuroStudio if people want to check that out. So there was a question about the difference between Pilates and yoga. They are totally different. So yoga is more of an exercise thing that is based on also meditative movement. In the Pilates world, we are very much based on exercises that move, that are connected to the core, that work like the small muscles that a lot of times are forgotten, like the rotator cuff muscles, the hip muscles. We have lots of crazy machines. We use spring weight. It's a very different thing. I always think it's funny that people think they're so similar, because I'm like, I think they're so different.
Yeah, I get that
Let's
sometimes.
see.
I'll say I'm a yogi and they'll say, oh, I do Pilates. And I'm like, can't you?
Well,
do
that's not the same. I mean, I like yoga and I have done a lot of yoga, but they're completely different. I think Pilates is a very nice complement to yoga because it does make you better at doing a lot of things in yoga. Because you need like a lot of core strength if you want to do some of the crazy stuff like arm balances and things like that. But we are more of a workout, and Pilates, Joseph Pilates, who's the person it was originally named for, was a boxer and like an athlete. He did do yoga, so there are some stuff that you'll see, and we'll name it a little bit different, and we might do it a little bit different. But he also did a lot of rehabilitative work, so it's more in the rehabilitative work
Mariska,
kind of thing.
I pushed a prompt to your other device that should
Okay.
be asking you to start the video.
Okay. Okay, now how do it is on, so how do I share it from there? Can you share it from there? It asked me if I wanted to speak or join. Can you try that again? Because it wants me to join audio, which I don't want to do. Okay, I mean, I can see the video. Can other people see the video? I can see it.
We don't see you, but I see I see your fused ladder.
Okay, excellent. So, we were talking about how you need to have stability to be able to have ability, and how we can address different body parts that aren't the problem leg. So, problem leg for me, MS leg, is my left leg. So, couple of things that you might see. This leg is kind of turned in some. That is muscle spasticity from 20 years or so work. And then I can lift this foot up, and I can't lift this foot up at all. Like I can lift my big toe up, and that's all I've done. So, in terms of walking, what I found that I did originally when I had foot drop was when I would take a step with my right and I need to get my left foot to come through, what I would do is I would swing it around. So that's called a circumvention. At the same time as I'm doing that, I'm actually dipping into my right hip. So that actually means that my left foot, if I was trying to lift it off the floor with my right hip kind of sticking out over here, it's going to be harder to lift off, because if I was walking without having MS issues, what would happen is if I step forward with my right foot, I'm not sinking into this leg, which is what you ideally are not doing. I would be actually lifting up out of this leg, so this leg would be pushing in more. So that is the glute medius muscle. And then this leg doesn't have to do as much work to step through if this hip isn't kind of collapsing in. So an idea of like having to have that stability to have mobility, I want to show you by making myself extremely unstable. So I'm going to sit in a chair and I'm going to try to lift my left foot without having my right foot be able to touch the floor. So this is spring weight. So this is a Pilates thing. So springs, literally like what you would see as a spring, but we use them in different ways. But if I put my foot in this, at this point, I can't push my foot down to the floor to stabilize myself. So if I can't get this foot down and you tell me to lift my left foot up, I'm going to have to do some crazy things. So I can like lean back and then lift this foot up, which would be some very strange walking if I was doing something like that. But if I just have this foot in, I literally cannot, I can lift my heel up, but I cannot lift my foot up. Now, if I put my foot on the floor and I'm stable, meaning like my hips are down, my feet are down, this is my weaker MS affected side. I turn this one so you can see it a little bit better. Weaker MS affected side, I can lift it off the floor if I can push down in this leg, which means that this is my leg that's creating stability, I can push down. If I want to feel more stability, so maybe this leg wants to roll in or wants to push out too much, I can try placing my hand on the outside of the leg or the inside of the leg and push leg against hand in either of those positions and see what feels like it's easier to move. So I know that for me, I need to work on my right hip. So we're talking about how is that force traveling up? So the force is traveling from my right leg when I need to step my left leg forward. So the force goes up my right leg, behind my back, down my left arm. So I also need to have my left arm move forward. So my right leg is stepping forward because that's how the force is going to work. But for the purposes of us not having a lot of time, I just want to give you a couple of exercises using a yoga block as your yoga people. So if I want to get my right glute to not want to dip out as much, I need to strengthen the motion where it pushes in. So I can do that using a block in a lot of different ways. I think you'll be able to see me okay here. So I'm going to place my right knee on this block to actually exaggerate how much it kind of goes out to the side. So from that exaggerated position, what I want to do is I want to push my hip in, and to make sure that my hips are level, what I'm going to do is I'm going to lift my left off the floor so that my sacrum, so the back side of my is going to be level enough, I always say, to place a martini glass on it. So I can dip down, which is like where my hip wants to be. And we'll work on pushing to get my hips to be level. You can do that also from a standing position, which is a little bit harder. So you can stand on something where, let's say you're here, you want to level off. So if you could look like in a mirror or something, you could say, okay, are my ASIs, so these are the two bony parts in front of your pelvis, are those level? Try to get those level and hold on to something, and each hold on to something. And then you could also do it as a yoga bridge, or like it's not a bridge in yoga, what is it? It's just like a pelvic. So it's like a little baby bridge. So if I was down on the floor here, and I lift it up, I'm going to try to lift my foot up so that these two bones are level. So it's again working that outer hip muscle that we want to have be stronger, so we're not dipping into that hip. And ultimately, what we want to do is making walking easier. So I'm concentrating on not dipping into this hip. That's really hard to think about all the time. It's like push, like try not to dip into your hip, try not to dip into your hip. So I don't actually love that as a cue for people. I prefer to make cues really easy. So think tall. You're going to be as tall as you can be. Tall without doing this, which I think a lot of people do when you say be tall, which is stick their chest out. I don't want this chest out kind of tall. What I want is crown of your head, like if I had a ponytail, crown of your head lifting up towards the ceiling. So instead of sticking out like this, you're thinking you're kind of pulling your abs inward, which would be a Pilates thing. And then think about your knees being soft and that your soft knees are leading you forward. So I didn't gain any ability to lift my foot up. I have tried to lift my foot up forever. I've tried all the things to lift my foot up. What I want to do is think about not collapsing down and making it harder to lift my foot up. I'm just thinking about my soft knees and tall spine moving forward, because to walk, you don't actually need to be able to lift your foot. You need to be able to take your knees, move them forward, and not let your foot just drop. So I don't have the ability to lift higher than not letting it collapse down to the floor, but I can walk without an AFO or anything when I do remember to do all of those other things. Now, that being said, I am not anti-AFO. I have an AFO when I go on really long walks, or walks when I don't know what to expect. What I do is I wear an AFO, and sort of my other cheat is to wear a heel that's like a nice fat heel that's like about 1.5 inches or maybe up to 2 inches, because that actually pitches your weight forward in such a way that's beneficial if you have spasticity that you kind of can't work around. But that would be something that I wouldn't necessarily recommend to everyone. That's just kind of a case-by-case scenario, but getting that idea of lifting up and not collapsing into your hips and thinking about things that aren't the problem, but are the fix, I guess would be a way I would like to have you guys thinking about it. So we can switch me, or I can switch me back to my other main thing. If anyone has any questions.
We just have a little more time. There are some good questions. So one is, do I need specialized equipment for Pilates?
No, we have actually a lot of stuff that we do on the mat. We use little things like TheraBands and stuff like that, which I mean, you can get for literally just mere couple of dollars. I mean, I have stuff that if you add up everything in this room is probably about $30,000 worth of equipment, but I also teach people. So Pilates equipment can be very expensive, but Pilates can be done very inexpensively.
Thank you. Is there such a thing as wheelchair Pilates?
There is such a thing as seated Pilates. So I absolutely do work with people in wheelchairs. I have sections on my website that are for people in wheelchairs. So we do a lot of seated things. So yes.
So people asked if you teach other places besides DC. Do you want to just give a short answer to that? Where they can find you and how they can find perhaps a Pilates teacher who specializes in neurological conditions such as you?
So I have trained about 1,500 people around the world. So my most recent teaching trip was to Paris. Pre-COVID, it was to Dubai. So I have people trained literally all over the world who have trained with me specifically on working with people with neurological conditions. And obviously Pilates for MS is my main thing because the one I know the best. So people I have trained and myself work on Zoom as well as working in studios. But if you want to find studios on the Neuro Studio, there's a find a teacher section, or you could email info@theneurostudio.com and we can find you a teacher. Most places, if you live near, I wouldn't even say a major city, because we've all over the US, we have people, Canada, Europe. So there's lots of people I've trained.
Yes, you have, including me. I very much enjoyed your training. Someone wants to know, is it equally beneficial to do mat Pilates as the machine?
I would say, well, there's lots of different machines. So I would say it can be. It really depends on if you need a lot of assistance. So during COVID, when I was working with some of my clients who use wheelchairs on Zoom, I was wishing I had some of my equipment to work with them, because like when I was talking about stability and things like that, like I can help people get stability. I can help offload weight of muscles using all these things that I have that have springs and stuff like that. But, you know, I did mat stuff a long time before I did machine stuff, because I couldn't afford it and I didn't have access to any of it. So I would say it's a case-by-case basis, but for a lot of people, you can have very, very good results doing non-machine Pilates.
And you talk about PT or physical therapy through your neurologist or doctor, or Pilates or a Pilates studio classes for seated Pilates. What's the difference between physical therapy through your doctor and Pilates?
Well, I would say physical therapy is always based on the physical therapist, and Pilates would always be based on the teacher, right? So it's like really what is the training somebody has and what is the approach somebody has. I would say if you're going to a physical therapist, I would look for somebody who is a neurophysical therapist, like somebody who specializes in neurological diseases. And hopefully, if you are seeing someone and you have foot drop and they aren't addressing anything other than your foot, I would say maybe go to somebody who has like a broader approach than that. I think a lot of times if you go to a PT who's maybe straight out of school, what you end up with is somebody who has a very narrow focus on what they learned in school. And so they're like, okay, you have foot drops, so I need to stretch your calf and like whatever. And it's like, but maybe that doesn't help somebody's walking. And not that I'm saying you don't need to stretch your calf and that that's not useful or that Botox doesn't work sometimes or whatever. I just, in my experience, a lot of times it's kind of weird. I think you had asked this question, Mindy, about where you thought it was confusing that I said, if you have foot drop or walking problems, you really need to strengthen your calf muscle instead of strengthening the muscle that lifts your foot. And that was something that a lot of people talk about. And I'm like, your calf muscle and that push off part of walking is where your knee bends and actually can help clear your foot through a lot better than trying to work on that tiny muscle that lifts your foot. Like you can actually get much faster, better results by strengthening your calves. And also strengthening your calves can help, strengthening and moving your calves can help with spasticity in the back of your leg. So figuring out stuff like that. I've had some very good and some very bad PTs. So, and also I've had some good teachers and bad teachers. So it's just say, look for a neuro PT if your doctor is recommending someone.
Thank you so much, Mariska, for being with us today.
Absolutely. Thank you so much for having me.
Wealth of information. And it's so unique to have someone so knowledgeable and also has been through this journey. You are truly a warrior. So thank you so much, Mariska. And Dr. Belkin is now going to introduce our next speaker. As you can see, our sponsors are on the slide, and I just want to say thank you again to our sponsors. They disappeared. Let me tell you a little bit. I just want to say thank you to Dr. Belkin for being with us and all the support that he gives to Yoga Moves MS and the mind. How much support the mind. We've been partners in helping improve the quality of life for people with MS for quite a while. He was an honoree for Yoga Moves MS, and I feel blessed, and the MS community is blessed to have you in our backyard in Michigan. And I'm very excited to hear our next speaker, which I'm going to let you introduce, Dr. Belkin.
Great. Thanks so much, Mindy. So yes, I have the pleasure and honor of introducing Taylor Gagnon. So Dr. Gagnon is going to be presenting about current research with Epstein-Barr virus and multiple sclerosis. So Dr. Gagnon, she is a graduate of Michigan State University's College of Osteopathic Medicine, where she graduated at the top of her class. She completed her neurology residency through the Beaumont Health System and Michigan State University's statewide campus system. During her neurology training, she developed a sincere interest and passion for helping patients with the diagnosis of multiple sclerosis and related disorders. She's therefore made the decision to dedicate her career to helping patients with multiple sclerosis, both from a clinical as well as a research perspective. She's currently completing her fellowship in multiple sclerosis at the Michigan Institute for Neurological Disorders Comprehensive MS Center. And I have the distinct honor and pleasure of being her fellowship director and getting to work with her on a daily basis. So, Dr. Gagnon.
Well, thank you, Dr. Belkin, for the introduction. I'm going to try to share my screen. Okay, I think you should be able to see it now. Okay, perfect. So we should be up and running. So thank you, Dr. Belkin, for the introduction, and thank you, Yoga Moves MS, for having me here today. So like Dr. Belkin, oh yeah, can you see it?
Do you see it? It says it's loading.
Oh,
yeah.
okay. says resume share. It says your screen sharing is paused. Let me try again.
Try again, and if it doesn't take it, I can launch them from my side.
Okay.
Dr. Gagnon, I have them ready to go.
Sounds good. Can you see it now?
See white?
It should be like, no, it should be a slide. It keeps saying that my screen sharing is paused. I don't know if you want to share it. That's just
Let
fine
me
too.
let me go ahead and try from my side.
Okay, sounds good.
Share.
Perfect.
And let me see if I can get you presentation view.
Okay, sounds good.
Let me see if I can get you better presentation view.
And I don't need the notes, just the slides are fine.
Yep.
Okay.
Perfect.
Okay. And then can I next this, or do you want me to tell you to next it?
Nope, you should be able to request control.
Okay.
And I should get a prompt when you do that.
Okay.
There you go. All right, you are in control, Dr. Gagnon.
Okay, perfect. It's still not letting me go to the next slide.
All right. I apologize.
No, that's okay. Oh, I see it right here. I think I maybe can now. Oh, there we go.
Was that
me?
you? Yeah,
I think so. Okay,
that's you.
Okay, so I'll go ahead and get started then. So I'm giving my presentation on the current research on the Epstein-Barr virus as it relates to MS. So the objectives today, we're going to talk about what Epstein-Barr virus is. We'll discuss the evidence, review the study itself, talk about what it means, and then how it still leaves us with some unanswered questions. And I'm just going to say in advance, some of my slides do have a lot of detail. It's just for your information to review later, but I'll try to go through more of an overview and keep it as straightforward as possible, with hopefully some time for questions at the end. All right, so to start, what is Epstein-Barr virus? It's actually a human herpes virus, and it infects about 95% of adults. So even though it affects about 95% of adults, still only a tiny fraction of those people will go on to develop MS. After infection, it does persist and kind of like a sleeping form in the B cells. And B cells are a part of our white blood cells that make antibodies. So it kind of persists in those memory B cells. It's transmitted via saliva. And then Epstein-Barr can kind of present a lot of different ways. So some people might have minimal symptoms, but it can also present as mono, which I'm sure many of us have heard of or been infected with. Mono symptoms can include fatigue, sore throat, swollen lymph nodes, swollen tonsils, and in some patients, they'll even get a swollen liver or spleen. All right, so what evidence do we have to support Epstein-Barr as a link to MS? So a causal role is supported by the increased MS risk after mono. You'll also get elevated blood antibody levels against these antigens for the virus. And then lastly, they did do autopsies on some patients with MS, and they took samples of the demyelinating lesions in the brain, and they actually found that some of these lesions tested positive for the virus. So now let's talk about this study. So the study was titled Longitudinal Analysis Reveals High Prevalence of Epstein-Barr Virus Associated with MS. So in this study, there were 10 million young adults on active duty in the US military, and 955 of them were diagnosed with MS during their period of service. They found that the risk of MS increased 32 times after being infected with Epstein-Barr virus. They also checked levels of serum neurofilament light chain. That's basically a big word, but it's a blood test that kind of checks MS disease activity. And they found that this blood test was only increased after somebody turned from negative to positive for the Epstein-Barr virus. These findings suggest that Epstein-Barr virus is a leading cause of MS. And at the minimum, it tells us that Epstein-Barr is a necessity or is a necessary event to develop MS, which is pretty remarkable data and kind of the first time we've ever seen anything like this. So let's talk a little bit more about the cohort. So for help, the research team turned to the US military, where the US military collects regular blood samples. So they check people every 6 months for HIV screening. So the researchers were actually able to go back and use those blood samples. And if you think about that, so 10 million individuals getting blood tests every 6 months, that's going to translate to over 62 million blood samples that they had to analyze. In the end, it did take 2 decades before they had enough data to kind of run a statistical analysis. So the study ran from 1993 to 2013. I know the slides here, the pictures are a lot going on, but basically it's just to show you that there is a racially diverse population of individuals. There were more men than women in the study. And as we know, MS is a more female predominant disease, about 70% female, but nonetheless, they did have at least 32% female of the MS patients. And then about 5.3% of these individuals were negative for the virus at the time of the first sample. I know that doesn't seem like a lot, but when you have 10 million individuals, that does translate into hundreds of thousands of young adults. So now let's talk about the sampling itself. So like I said earlier, they took patients and tested them for Epstein-Barr. So there were 801 MS patients and 1,566 controls. One of the 801 MS cases occurred in an individual who was negative for the virus at their last sample. And at baseline, there were 35 MS cases and 107 of the controls that were negative for the virus. However, all but the one mentioned above did test positive for the virus before the onset of MS. And then the average time from the first positive sample to the onset of MS symptoms was about 5 years. I'm not sure if it's easy or difficult to see this graph, but basically what I was trying to show is that they also checked another virus called CMV. And this virus is similar to Epstein-Barr. They're both human herpes viruses. They're both transmitted via saliva. So they checked both of the viruses and then looked at risk of MS. So you'll see the blue and the green really separate with the Epstein-Barr, meaning they definitely showed the increased risk, but you really don't see that with CMV. And same thing, if you look down at the orange dots below, you can see that there really was no increased risk of MS with CMV. So how do we know that this is true of Epstein-Barr and not other viruses? So they actually tested over 200 other viruses to determine if MS could be related to dysfunction of the immune system from any virus, or if another specific virus would elicit that same response that Epstein-Barr does. And as you can see by that orange line, you see that significant increase with Epstein-Barr that you don't see with any other virus that they tested, which again suggests that Epstein-Barr virus is a cause of MS. So now we're going to talk about, again, those serum neurofilament light chain levels. So again, that's a blood test that's reasonably accepted as a biomarker that represents MS activity. So that means that if you have high NFL levels, then you likely also have high MS disease activity. So they found that these levels increase as early as 6 years before symptoms of MS. And then in patients who were EBV negative at baseline and went on to develop MS, those levels were similar to those of non-MS controls, meaning there were no signs of MS activity prior to testing positive for Epstein-Barr virus. And you can kind of see that in this graph again, if you're able to see it, the green being MS, the blue being not, and seeing that the increase really came with MS. So this does indicate that EBV infection preceded not only symptom onset, but also the time of the first detectable pathologic mechanisms underlying MS. Okay, so how do we know that Epstein-Barr virus leads to MS and not the other way around? This slide is really wordy, but I'm going to try to summarize it the best I can. So basically, to explain a 32 times risk for Epstein-Barr virus, it's almost impossible for there to be an alternate explanation. You'd need something that would confer at least a 60 times increased risk of MS. And at this point, the existence of an unknown factor that could increase the risk of both Epstein-Barr and MS by 60 times or more than 60 times is unlikely. There are no good candidates or even hypothetical candidates that could increase the risk that much. So based on this data, it's conclusive that Epstein-Barr virus is, again, a necessary event to go on to develop MS. As I mentioned earlier about that one case, which I'm assuming you're all wondering about. So the one case that was negative for the virus at the last sample was obtained 3 months before the onset of MS. So the question is, could this potentially suggest that Epstein-Barr was not the cause? It could, unless we think a little deeper. So number one is, did this person get infected after the last sample was drawn? Like I said, it was 3 months prior. So did their infection come after that? Number one. Or number two, did they fail to test positive, meaning they were still exposed to the virus, but that, that blood test just didn't show that positive result? Or three, is there a chance that this patient could have been misdiagnosed with MS, meaning that they had something else that was, similar, kind of looked like MS, but wasn't MS? I think those are all really good questions, though obviously we don't have answers to them at this time. Nonetheless, I would say that the extremely low risk, MS risk in an EBV negative individual suggests that most MS cases are caused by Epstein-Barr virus, which raises the thought, could these potentially be prevented by a suitable vaccine? So what questions are still left unanswered? So like I just said, I think that one question, most of these things are being studied, but one question is, will vaccination against Epstein-Barr virus prevent MS, or could it potentially reduce the incidence of MS or change the course of the disease? I think that's a question we still don't have the answer to, but that hopefully there's research coming. The next question is, if we treat mono with antiviral medications against the virus itself, could that potentially reduce the incidence of MS, or again, could it alter the course of MS in any way? And then another unanswered question that I think we still have is, will treating MS with disease modifying therapy that targets the virus, could that potentially alter the course of MS as well? So I think most of these things, they're starting to study and really look into, but I don't think that we necessarily have definitive answers for any of this yet. So before I go on to questions, I just want to, kind of summarize and reiterate. So, I did say that about 95% of patients have been infected with the Epstein-Barr virus, but I just want to say again, only a tiny fraction of these patients do go on to develop MS. So just because, you or a friend develop Epstein-Barr virus or mono, that does not mean that you're going to go on to develop MS. However, on the other side, it does seem that based on, this paper and this data that we reviewed, that Epstein-Barr virus is a necessary event to go on to develop MS. So I think that's all I have. If there are time for questions, I can do my best to try and answer them.
Thank you, Dr. Gagnon. There are a few. One is, I had infectious mono when I was 15. My MS symptoms didn't start until I was about 56, diagnosed at 58. Is this normal?
So I don't know that I can entirely answer that, so I'll do my best. But my understanding is there's not one specific time that leads to MS, or that is, time from diagnosis and time to MS. from this paper, they just said the average time was about 5 years from the last blood sample to testing positive. But based on this paper, that's kind of the only information I have to try to answer that question.
Thank you. Next question. I'm a father with MS since 1998, and my daughter has tested positive for mono at age 9. In parentheses, she wasn't kissing anyone. Will she definitely develop MS?
Nope. So just because you have MS or a family member has MS, and then you develop mono, that absolutely does not mean that she will go on to develop MS. Even though, 95% of adults have had MS, and, most of us do not, or have had not MS, sorry, have had Epstein-Barr virus, but most of us still don't have MS. So that does not mean that she will get it. No.
But could it? Is there a correlation?
I don't ever have a crystal ball to know. Obviously, this paper shows that EBV potentially increases risk for MS, but it doesn't mean that she would get it. But again, 95% of us have had MS or have had Epstein-Barr virus, and not nearly that high percent develop MS.
This is related. I have MS and my daughter has had mono. What does she have to do to avoid developing MS?
So far, there's nothing specific that I know of that we can, do once we've had mono to prevent MS from developing. Like I said, there's a lot of things that they're researching, and if they find something, that potentially changes the viral course, I'm sure it will be in the news and many of us will know, but right now there's nothing specific that I know of.
Hey, let's see. If daughter had EBV in past, I have MS, should we test for SNFLs? Neurofilament light chain.
So that's kind of a biomarker that it's reasonably accepted, but it's not something that is necessarily easy to routinely test for. So I don't know that I have an answer to that either. Sorry, I would say that.
You know what? It's good to say that we don't have the answer yet.
Yeah, we don't have all the answers.
Why did they give you a crystal ball when you graduated?
I wish I had one.
Did they tell you they were going to?
I wish.
If over 90% of people have the Epstein-Barr virus, why is it considered a cause of MS?
So because when they tested, patients that did not have Epstein-Barr and those that did, they found that in order to have MS, it was almost a necessity to have tested positive for the virus.
Okay. What is the test for Epstein-Barr? Do you mean treating MS with DMD will treat the Epstein-Barr virus?
So the test for Epstein-Barr virus is a blood test. And then the disease modifying therapies that we have now do target the immune system, or, many of them do. So potentially, maybe some of those could be working by modifying the immune system, and potentially thereafter modifying Epstein-Barr. I don't think that we have an answer to that yet. They are studying disease modifying therapies now that, target more Epstein-Barr virus, and we're waiting to see the data to see how that affects MS.
Okay. What do you think is a credible online resource to find future information?
I think the MS Society always has good information. And then there is something called PubMed where journal articles are published. Some of them are a little bit complex, but nonetheless, it's a way that the real-time data is posted.
Okay, I see I missed one other one. Can a fresh herpes outbreak trigger an MS episode?
I don't know the answer to that. I mean, you can get pseudo relapses, anytime you have infection, but I'm not sure about herpes leading to an MS episode.
All right, I think that's it related to the Epstein-Barr questions.
Okay.
Oh, wait, here's one other one. Last one, I promise.
Okay.
Those who went to develop MS, did the researchers also investigate any other factors or conditions that people had in common?
They looked at all the other viruses, but I think the data here that was basically blood tests looking at viruses and the neurofilament light chain levels.
All right. Thank you so much.
Yeah, thank you for having me. I appreciate it.
Yes, thank you for sharing. This is obviously an area of much interest. So thank you so much for sharing your time.
Of course. Thank you so much.
All right. Dr. Voci is going to introduce our next speaker, which I'm super duper excited about. I was so excited when she said she would present today.
Thank you, Mindy. Yes.
Take it away.
Yes, thank you. Yes, we are all deeply honored to have our next guest with us. But Dr. Emmanuelle Walbant received her medical degree from the University of Lille in France. She then finished training in France as well as at the University of California, San Francisco in adult neurology, neuroimmunology, and MS clinical research. She is currently a professor of neurology and pediatrics at UCSF. She has served as the Race to Erase MS medical director since 2001. She also directs the Regional Pediatric MS Center at UCSF and is the president-elect of the Americas Committee on Treatment and Research in MS. Dr. Walbant serves or has served on numerous committees, including the Clinical Care Fellowship and Research Grant Review and Research Programs Advisory Committees of the National MS Society. She is chair of the Clinical Trial Task Force of the International Pediatric MS Study Group and a steering committee member of the U.S. Pediatric MS Network and International Pediatric MS Study Group. She directs translational research projects and mentors junior investigators on various clinical research and career development aspects in the field of MS and its related disorders. In 2018, Dr. Walbant also started an international consortium, International Women in MS, to help foster diversity and community spirit amongst clinicians and scientists from all over the world, as well as to promote diversity in professional organizations and help mentor junior women in the field of MS. Her specific interests include the translation of promising agents from the bench to bedside to help advance patient care, as well as risk factors for MS susceptibility and disease modifications in pediatric and adult MS. Dr. Walbant will be discussing the growing understanding of the microbiome as it relates to MS. So Dr. Walbant, we thank you for being part of our Yoga Moves MS community today. Thank you, and go ahead.
Thank you for the introduction, and I feel sorry to have a bio that is taking so many words. I should have shortened it.
No, you should be proud, never apologize.
I am not apologizing. It's just maybe not everything is needed in the bio. So today I will talk about some work that has been done all over the world. So you probably see my screen now, and I think you should see the first slide full screen, right? Yep. So I want to give a critical update about what is known about gut microbiome and MS, because occasionally I've read either in scientific or lay articles things that were not really appropriate in terms of our current understanding and the translation to patient care. So the first thing I wanted to say is that why do we care about the microbiome? What's remarkable is that there's basically bacteria and viruses all over our body, inside and outside. There are tissues that are virtually sterile, but most of our skin and guts, for example, are covered in bacteria. That means that there's actually much more genes that are on our body than genes we host that are our own genes. So there's more than a 200-fold difference. So if we were just being genotyped, including all our skin and guts, most of what would be found would be actually not our own genes. The microbiome is not only made of bacteria, it's also made of fungi, some very small cell called protozoa, and viruses. They are, so the reason why people have focused on the gut microbiome is because it is really the largest bacterial community in our body. and it's contributing to digest some food and produces some vitamins that otherwise would not be absorbed well by the diet. And the barrier, so I'll show you afterwards on another slide, but there's a thin layer of cells that is a barrier between the bacteria that are in the gut and the entry in the gut. So it prevents the aggressive bacteria to actually enter the rest of our body. What's been very exciting is that over the past 20 years or so, there's been a growing understanding on how the microbiome and more of the work has focused on the gut microbiome, but there's also work that has looked at, for example, the dental or the sinus microbiome may regulate some of the immune response. This is a field that's reasonably new because the microbiome did not exist until the late 1990s, but there's been really a lot of enthusiasm about that developing field. The slide here is just confirming the role of the gut microbiome. So there are 100 trillion gut bacteria, so it's a huge community. Those bacteria typically contribute to the education of our immune cells, but they also can contribute to some diseases, including autoimmunity, we think, when there's an imbalance between different communities of bacteria. The imbalance of the bacteria in the gut can lead to a little bit of leakiness in the gut that allows the entry of some molecules that are in the gut and otherwise would not enter our body. And sometimes these are microbial products. The bacteria that live in the gut are actually modulated by all sorts of normal environments, but also less normal environments. For example, cigarette smoking or use of antibiotics are going to change in a major way, at least for several weeks, the gut microbiome. So on this slide here, I want to get a little more in depth into how we think the microbes in the gut may actually influence ultimately a disease like MS. So as I said, in the gut, there's a lining that is not a flat surface, but that is really very complex, and that lining is made of cells that protect from entry of bacteria or entry of different products of degradation from bacteria. And you can see that this lining is also very close to some nodes that are critical in the training of immune cells. And these little nest of immune cells are themselves in relation with lymph nodes around the gut that in turn contribute further to the training of immune cells. And then these immune cells can go in normal blood vessels. So we think that there's really the interplay between the normal bacteria that are in the gut, the integrity of the barrier of the gut, and what we refer to as mucosal immunity, because it's under the mucosal layer of the gut that may contribute to brain autoimmunity. Many years ago, so it was in the early 90s, I think that the work from John Goverman was really what started to open the eyes of researchers in the world of MS, because she published a paper that showed that mice that were raised in a completely sterile environment would not develop the animal model of MS called EAE. And when these mice were actually fed non-sterile food, they would ultimately be able to develop EAE. So these were mice that were engineered to develop EAE in the first place, but the contribution of the environment, whether it was sterile or not, was very clear. So it took more than a decade for people to get more excited about bugs, basically, in our environment and how they may influence animal models of MS, and then ultimately some interest in how they may be important in MS itself in humans. I selected only one of the many work that have been done in animal model, because I think that's been really the translation of what we know in humans back to the animal, and then suggesting that there was really a major role of the gut microbiome that occurred in MS. So this is a study that was very cleverly designed by some German colleagues that looked at stool samples from twin pairs. So they were similar twins, but one had MS and the other one was healthy. So they looked at those samples and how, if they were fed to mice, what was happening to these mice. And what you can see here on the slide is that for the healthy twin, there was actually few mice that over time developed MS. And these were mice that were also reasonably engineered to develop spontaneously EAE, the animal model of MS. But when the same colony of mice was fed samples that were coming from the twin that had MS, there was actually a majority of the mice that developed that animal model of MS, EAE. So that really raised a lot of hope in the community about what we could do for patients with MS. What we know from the gut microbiome is that there are changes in the different communities that are over time changing because of aging. And you can see here, it's just, I won't go in detail, but you can see that these are 4 or 5 of the largest families of bacteria that live in the gut. And you can see that the spread of these bacteria over time is a little different. There are the factors that influence also the profile of the bacteria that live in the gut. So I mentioned the age. We think that disease duration in MS may play a role, probably because of the medications that patients take. The geographic origin of patients, the season also makes the gut microbiome change, of course, the diet. And then lots of things such as supplements, vitamins, probiotics, and medications modulate the microbiome. And now we're starting to have a better understanding on how the genetic makeup of people influences the microbiome. And I wanted to lay a good picture of the landscape, because when you start looking at the MS studies, there's limitations that are in part related to these environmental changes that may affect the gut microbiome. So there's more studies that now have been published in MS, but overall, the vast majority of the studies have been small to moderate in size, which means they had between 10 and 60, 70 patients. And very often, at first, those studies enrolled patients who had very long disease duration and were on treatment for MS, which we know can affect the findings in the gut microbiome. Most of the studies have looked at patients who had MS from the perspective of looking at their stool samples. There was one study actually that looked at samples from the duodenal mucosa. So patients who were undergoing fibroscopy, for example, of their stomach because there were symptoms suggestive of maybe an ulcer. But most of the studies have looked at stool samples. When we look at the microbiome, we look at a lot of different ways to describe the microbiome. So we look at the overall community composition, and we call that diversity. So the diversity, how many bacteria are found in a given individual, or what's the number of bacteria that are found that differ between individuals. And then we can look also at the microbes themselves. So their presence or their abundance. And then we can look at pathways. So looking at large clusters of bacteria that like to hang out together or that are involved in specific metabolism. Going back to the German study I mentioned earlier, I think that study and then subsequent studies have really showed that the diversity was not very different from a healthy twin and their other twin that had MS. And I think that's basically been reproduced most of the time by other studies. So if it's not the overall diversity, what is it? Is there specific bacteria that are actually associated with MS? Well, the response to that is very complicated because, as I said, most of the studies were small. They may have been done in patients who had MS for a very long time, that had been on different types of treatment that can alter the findings. And then the controls that are used in these studies to find differences between MS patients and people who don't have MS, the controls may also have been sometimes a little heterogeneous in the way they were selected. So here it's just a slide showing you some of our findings in a pediatric MS study, looking very early in MS, after MS onset. And the slide is just recapitulating here some of the bacteria that are more abundant in patients with MS compared to controls. And then you see also there's 15 or so bacteria that are less abundant in patients with MS compared to controls. And some of these bacteria are actually specific to our study, but some have been reported by other people who have looked at differences between adult MS and adult controls. And the reason I was interested in pediatric MS is because we know that children have been exposed to much less environmental changes because their life has not been as long. And as such, the findings may be less polluted, if you will, by different exposures to various medications or diet changes and so on. Then what we can do when we look at the microbiome, we can look at what's the function of the bacteria that are found increase or decrease. And here, this was a study that looked at metabolic pathways. So, for example, a group of bacteria that together, for example, here you see this is a large group of bacteria that contribute to the making of urate, for example. And so in that pathway, there's a lot of bacteria, but there's another pathway that was underrepresented also in MS patients that had only 3 types of bacteria contributed to the pathway. So we can look at bigger pictures at just one bacteria alone, because we know that there's a fair amount of redundancy with certain bacteria, and some can contribute similarly to the metabolism. Then some studies have looked at how the microbial abundance in the gut may influence the expression of genes that regulate the immune response. And so I will not go through this, but I just wanted you to know that we can also look at increase or decrease in the stimulation of some immune cells relating to the abundance or the presence of specific bacteria in the gut. And these immune cells are actually in the peripheral blood, showing really that what's happening in the gut has consequences that are detectable at the level of the blood in patients. I'll switch quickly here to something that in my mind is even more valuable to discuss with patients who have MS. So I was just talking about differences between patients who have MS versus patients who don't have MS, and how we think these differences may influence the onset of MS. But now I'm going to talk about changes that may influence the course of MS. So, for example, taking patients early on who have MS shortly after their disease onset, and then monitoring over time how the abundance of specific bacteria may be associated with increased risk of relapse or scars on the MRI. So this is a slide we often use to talk about disease activity in MS. So we can talk about the clinical aspect of the disease for patients who have relapsing MS. We can see bouts of symptoms that we call relapses that recover or don't recover fully, with over time a secondary progressive phase. But we can look also under the radar screen at what happens at the MRI level. And we can see here, for example, every time there's a yellow arrow, basically new scars that develop. And we know that there's more scars that develop on the MRI than flares of MS that patients would experience. So keeping that in mind, we designed a study in pediatric MS, again, because we think that there's less kind of changes that are related to, for example, having high blood pressure or smoking, and that we're closer to the reality of what happens in our body. So we enrolled 55 pediatric onset MS cases throughout the US. And we actually identified controls who were healthy in the same age range. We collected a sample shortly after onset of their disease, and then we looked at what happened afterwards in terms of their clinical symptoms, but also their MRI changes. The study identified that there were two types of bacteria that may be associated with an increased risk of relapse, so an increase in the abundance of these two bacteria, Blautia and Kristenacea. So some of these bacteria, as a side comment, have very complicated names. That's why I'm trying to avoid mentioning them, because I think it's all a big I wanted to have a big picture of what's happening in the field. So here in our study, we found two bacteria that, if they were increased in abundance, those patients tended to have more relapses. And similarly, we had also one bacteria that was associated with presence of new lesions on the MRI. But that bacteria, actually, an increase in the abundance of that bacteria was associated with a lesser chance of having new scars develop on the MRI. So then we looked at communities of bacteria. As I said, bacteria like to hang out with some of their little bacteria friends. So we're really more and more looking at communities in general, as opposed to a single bacteria. And here in this same study, we identified two clusters of bacteria that were strongly associated with the presence of new lesions on the MRI, whether we looked at those that were enhancing or those that were not enhancing. So that was very interesting. However, I think at the end of the day, what do we know and what is going on in terms of translating all this knowledge for the care of patients? I would say that at this point, there's really limited amount of information about how the gut microbes or clusters of those microbes are associated with the risk of MS flare or new scars on the MRI. So there's very little so far to guide intervention. Nevertheless, there's different researchers who have jumped ahead and have tried to do some intervention studies. So try to treat patients with MS with different ways to intervene on the microbiome. There was a small study of probiotic supplementation that was done at Harvard that just was intended to look at the changes in the immune response, but not at all at the efficacy, because the study is way too small. Also, I want to say that there's hundreds of different probiotics. So which one would you pick? And in that case, the researcher picked a probiotic that was offered by them with a grant to study in MS. Some people think also that, for example, prebiotics such as dietary fibers could be an interesting way to modulate the microbiome. Live biotherapeutic products also are considered. Some people have started to do microbiome transplants based on the animal model that I discussed early in my presentation. I think that the transplant, in my mind, is not always necessarily a sustainable way to do it, because it probably will take long treatment to alter sustainably the gut microbiome. So just do one transplant probably will not lead to improvement of a disease such as MS. So in conclusion, I wanted to say that we still need to establish causality between those bacteria and the disease course. It's really not completely clear whether there's a true gut microbiota signature for MS risk, and also how these bacteria contribute to MS scores. It's really important to sort that out so we can design trials to intervene based on evidence that will make us less likely to fail. So I wanted to thank you for your attention, and happy to take questions.
Thank you so much, Dr. Wobant. Oops, there's my video. So we have a few questions. One is, do you recommend a specific diet or what not to eat to help with gut health, which is a segue to our next speaker, but perhaps you could answer it briefly.
So I think I will let the next speaker touch on that, because I think when we talk about diet, it's not only diet for MS, but it's diet also for general health. And diet, as it may provide nutrients that are good, or nutrient, for either training the immune response or not. So I will let and modifying the microbiome. So I think the answer, I don't want to steal any thunder from the next speaker. So I will not answer that question. Sorry.
That's okay. This is all good transition to our next speaker. Next question, this may also be a prepper for Dr. Katzen. Let's see, has healthy gut been defined, or does it depend on each person?
So healthy gut, I don't think it's really clearly defined, but as long as there's no leakiness of the gut, it means that the gut microbiome is healthy. I think when there's something called dysbiosis, which is basically an imbalance between different communities that result in inflammation and breakdown of the gut barrier, then that's when it's not healthy anymore. There's also instances of unhealthy microbiome that is related to kind of increased abundance of bacteria that may be really very aggressive bacteria that usually are not hosted in the gut. That can result in very severe infection, and that type of complication is typically coming after antibiotics, the long and aggressive antibiotic course. This is a rare complication of antibiotic course, but that's when people have started to develop transient microbiome transplant, because in that situation, we know exactly which bacteria we're trying to fight and get rid of, and which bacteria actually help to do that. So, I think that there's a lot of variability from one individual to the other. There's millions of people who have a healthy gut microbiome, but there can be huge differences depending on their type of diet, the season, because the season influences the diet, and so on and so forth. So pretty complex stuff.
It sure is. And I'll let you determine whether these, we should let Dr. Katzen answer them or whether you're going to. Once, they keep moving the questions on me. When someone has MS, can their microbiome be studied to give baseline today?
Yeah, so that's a good question, because very often what has happened is that the microbiome studies, because of the complexity to set them up and also the cost, have typically collected only one sample per patient. Now there's more and more attempts to try to collect several samples from a patient over time to understand really the variability and the consistency across the microbiome and how it may relate to MS. So people can give samples, but typically you need to work with a group that is doing research on that topic. So very often we actually freeze samples before we analyze them, because we need to have enough to analyze. And those samples are stable at -80 degrees in a freezer.
Do you recommend any probiotics for gut health?
So I don't, because there's so many probiotics, and that's a question many of my patients ask. I think that a very diverse diet is probably, with lots of fruits and vegetables, is probably contributing to a healthier gut microbiome. In some instances, I recommend probiotics to my patients if they have recurring urinary tract infections, because the urologists are starting to use more and more probiotics to kind of rebalance a little bit better the microbiome, the gut microbiome, but also probably the microbiome around the pelvic floor.
Do you think kefir, kombucha, or yogurt can be beneficial for gut health?
Probably. There's no direct, there are some studies in MS. I don't know of a study that has looked at that, but this is definitely something we're capturing when patients donate a stool sample. We're asking whether they take some of these products, because it can change the findings.
Is gastritis a symptom of dysbiosis?
Gastritis it can be a symptom of lots of different things. It can be related of inflammation of the stomach because of medications that people take that can, like non-steroidal anti-inflammatories, can irritate the lining of the stomach. Some people have also increased stomach juices that can do that. And sometimes it can be related to dysbiosis. For example, so it's not gastritis, but it's been known for a long time now that, for example, stomach ulcers, some were actually associated with Helicobacter. So some bacteria can induce stomach ulcers. And what's actually very tricky is that we think in some conditions, some bacteria may participate to increase the risk of some cancers, for example. But at the time the cancer is diagnosed, if you look at these bacteria, they're not there anymore. So, the biology is very complex, and it's important to understand the limitations of what we do to be able to really interpret appropriately the findings of our studies.
Okay.
I have a question about, is C. diff common with MS patients?
Is C. diff common with MS patients?
No, and C. diff is actually the bacteria I was referring earlier as a very aggressive bacteria that has been treated with microbiome transplants. Some people have C. diff and don't have symptoms of it, but some people have very severe gut complications. But it's not necessarily common, more common in MS.
Does the healthy gut in MS patients change with COVID-19 vaccines?
You guys have really complicated questions. I don't think people have looked at that. So we know that different medications for MS, for example, the oral treatments or even the injectable treatments or the IV drip treatments are associated with changes in the gut microbiome. I don't think there's really data looking at what happens after a vaccine. But one has to understand that when there's interventions such as taking antibiotics or steroids for an MS relapse, the changes that are induced by this treatment in the gut microbiome are actually temporary. And typically the gut communities go back to previous to the treatment within a month or 2 months. It's only with treatment that you take on a regular basis, long-term, that can induce long-term changes in the gut microbiome. So I would not expect a vaccine induces long-term changes in the microbiome.
So there's one, I think she's clarifying that imbalance in the gut impacts inflammation. So are you saying that an imbalance in the gut impacts inflammation?
Yeah, so we know that so there are differences across people and within the same person across different seasons or diets that don't result in inflammation, but there are some imbalances in which some communities become predominant or become so tiny that it's promoting inflammation in the gut. So we know that some diseases like Crohn's disease and irritable bowel syndrome, for example, can be associated with some of that. But there's also more and more evidence that some of these imbalances can result in different type of autoimmune, whether it's lupus or MS.
Okay, how does someone know if they have leaky gut? That's going to be your last question.
We don't test for that because it's really, we don't have any good way to evaluate that. You could look at the composition in protein in some of the stool samples, or look at the immunoglobulin level of different types of immunoglobulin, but this is not something that's done commercially. And I don't think that in the field of MS, there's any reason to test for that at this point, because we don't have an answer of, is it bad for everyone or it doesn't matter, it's just there.
Thank you so much, Dr. Wellbamp. That was, I've been looking forward to this all year since you said yes.
Wow.
It's just such a specialty and it's such new information. So thank you so much.
Well, my pleasure, and congratulations for a great meeting and a great lineup of talks.
Yeah, we're very fortunate. Our next doctor is going to complement your conversation and presentation that you just had, and Dr. Alana is on now. I want to take 1 minute to just take a little break. We have MS warriors that we did videos of, and so this is a 1 minute, 10-second video of Stacy. So we're going to put her on, and then Dr. Katzen's coming on right after that. So maybe you want to stretch, move, but keep your eyes on the screen.
I always wanted to be a doctor. I just never knew what kind I wanted to be. And then when I was diagnosed with MS, I like going to my doctor's appointments and seeing my MRIs and looking at everything. I just wanted to do that. I have to take medicine, but everyone has to take medicine. I try to take breaks and go on walks with my friends and see my friends, because that's a big part of just like keeping me sane. I'm in a very tough pre-med curriculum at the University of Michigan. I'm able to function, I'm able to be a normal student, go to the football games, go to parties. Like, I'm able to do everything that a normal student does. I have this like very real reason of why I want to help people in the future and why I want to go into medicine.
Okay, thank you to our sponsors and our partners and Dr. Belkin, who's going to introduce our next amazing speaker. We're so fortunate to have both of you on at this moment.
Okay, great. So yeah, these are great talks, and this next one, nutrition in MS, is so relevant and so important. It's something we get questions about every day. So I'm certainly excited as well to hear it. So Dr. Ilana Katz-Sand, she received her undergraduate degree from the Wharton School of the University of Pennsylvania, where she was elected to the Beta Gamma Sigma Honor Society. She obtained her medical degree for the Columbia University of Physicians and Surgeons, where she was elected to the AOA Honor Society, the Arnold P. Gold Humanism in Medicine Honor Society, and received the Helen Sciarra Prize in Neurology. She completed her neurology residency at Columbia University Medical Center, where she was elected chief resident in her final year, and was recognized by the Arnold P. Gold Humanism Foundation Circle of Excellence in Teaching. She then pursued a 2-year fellowship in multiple sclerosis at the Corinne Goldsmith Dickinson Center for MS at Mount Sinai, funded by the Sylvia Lowry Fellowship Training Grant from the National MS Society. She joined the faculty at Mount Sinai following the completion of her fellowship in 2013. Dr. Katz-Sand is currently the Associate Director of the CGD Center for MS. She cares for patients with multiple sclerosis, neuromyelitis optica, and other neuroimmunological conditions. She received a Coleman Family Award for Excellence in Physician Communication in 2016 and 2022. She is heavily involved in research and is currently the principal investigator on several studies at the center, with a focus on clinical and translational research and a particular interest in how environmental factors, especially diet, affect prognosis. Recent and current studies include a pilot clinical trial of a dietary intervention for MS, observational studies related to diet and other lifestyle factors in MS, an investigation of the role of the gut microbiome in MS, a study on the mechanisms of neuronal degeneration and progressive MS, and a pilot clinical trial of cetirizine as an add-on for neuromyelitis optica. Her work has been funded by the National MS Society, the U.S. Department of Defense, and the Guffey-Jackson Charitable Foundation. She is a member of the National MS Society's Wellness Research Working Group and co-director of the CGD Center's MS Wellness Program. So certainly here is Dr. Ilana Katz-Sand.
Thank you so much. Thank you so much for having me today. It's really exciting to be here. And I'll start by saying that as I try to pull up my screen here, it was really fun for me to see that video of Stacy Hirsch just now. So Stacy actually volunteered in our center last summer, and we tried to get her some research experience, and we're very excited that she is interested in either going into medicine or something in healthcare and wanting to move the field forward in MS. So we think Stacy's awesome. Okay, can you guys see my screen? Let's get this. Yeah, thumbs up. Okay. And then let me just fix this. Okay. Everyone can see? Yes? Okay. So I'm really excited to be talking to you about nutrition for MS today. So just as an overview in terms of what we'll talk about today, we'll first talk about why we're talking about this in the first place. We'll think a little bit about some mechanisms by which we think diet might be important. Then we'll get into what I would consider the most common things that people ask me about. So some of the different dietary components and whether those have a role in MS, and then some of the patterns. And then we'll get into some of our current recommendations and kind of where things are going. So the first question is, why are we interested in diet? And I think there's two main reasons for this. One is that people who live with MS are asking us about this. So this is one of the first things I noticed when I started taking care of people with MS, 10, 11, 12 years ago, was that everyone was asking us this question, what can I do? What kind of diet should I eat? And we just were saying, we just don't know. And that was not a satisfying answer. As a clinician, it's not satisfying for me, and it's certainly not satisfying for the people who are living with MS in terms of what to do. I think people are interested in this because this is something that everyone can do to be really proactive about living with MS. And I think it's really appealing that this is a natural approach, which I recommend as something to complement traditional disease modifying therapies. The other big reason is that we have increasing scientific rationale. So at this point, we know that there's a very strong environmental component to MS, which we'll talk about in a moment. And at the same time, there's a lot of variability in outcomes. So we know that if we have two people who start, diagnosed with MS at the same time and put them on the same medicine, one of them might do really great and the other one might really struggle. And so it's on us to try to continue to search for what are those modifiable factors? What are things that we can do that are going to make people's prognosis better? And I think diet is a really good place to look. We have good research at this point linking medical comorbidities, so things like diabetes, hypertension that are related to diet, of course, with MS outcomes. And then we have some preclinical research, which means, animal models and things in test tubes and stuff in the lab, which have shown us there's some really good ideas out there in terms of mechanisms by which this might be important. And we'll talk about these in a moment in terms of dietary metabolites. And we just heard Dr. Wabant give a fantastic talk about the gut microbiota. And then we have some observational studies and some early clinical trials that I'll tell you about. So this slide relates to a lot of the topics that we're talking about today. So we think about the etiology of MS in terms of what pushes people into this diagnosis, but then we also need to really be thinking about, okay, well, beyond that, someone is diagnosed with MS, what are the factors associated with the outcome? And there's actually quite a bit of overlap, especially in terms of the environment. And with both of these, we know that there is a genetic predisposition, both in terms of developing MS, the etiology, as well as in terms of severity, but it's relatively small. And really what seems to be big is the environment. And there are a few factors that we know about. We talked a bunch about EBV, for example, and some other factors, but there's a huge chunk that's really not explained. And so we need to be looking at some other things. And I think that's where diet comes in. So let's think for a moment, how could this actually be? How could diet have an effect in MS? I think there's two big categories to think about. One is indirect effects mediated by these comorbidities. So things that we know to be associated with worse outcomes in MS. We have good research establishing these things now. So having a high body weight, having cholesterol levels that having an adverse profile. So having a high LDL cholesterol, for example, is associated with having more MRI lesions and having greater MS-related disability. And then other vascular risk factors, having high blood pressure, having diabetes, especially when they're not well managed, are associated with worse outcomes. And of course, all of these things are tied indirectly to diet. But then I think the part that's even more interesting is thinking about what are the effects that are actually directly related to diet. So what about direct effects of the foods that we actually ingest? And then there are effects that are mediated through the gut microbiota. So you heard Dr. Wabant say that diet is one of the factors that affects the microbial composition, meaning which bugs are actually there in the intestines. And depending on which bugs we have, that has an influence on that mucosal immunity that's there in the gut. And that has an influence distantly, including in the brain and the spinal cord. Things that we ingest also induce the gut microbiota, whatever bacteria are there, to produce different metabolites. And those, again, diffuse into the circulation and get all the way into the brain and the spinal cord. So I think we need to think about foods the same way that we think about the medications. And we think about medications, pharmacologic interventions as these chemical structures, and we think about how they bind to certain receptors on certain cells. And I think we need to be thinking about foods in the same way. So foods have different molecular components, which have different structures, and they bind differently to different cells and, trigger those cells to behave in different ways depending on what we eat. And that leads to this slide, which I put here as a reference, because I think this is a great paper. I know people were asking about, resources and things like that. This is a very academic paper, but it gives a nice schematic here of this idea of a gut-brain axis. and the communication between the brain and the gut and how that happens. And diet is a big part of that. Okay, so now we'll get into some of the evidence for dietary components in MS. And I know we're a little off time, so I'm going to try to go through some of the stuff a bit quickly. I'm always happy to talk offline if people, have further questions, and we'll take some time for questions at the end. But what I wanted to include here was some of the components that I feel my patients ask me about the most frequently, the things that come up the most frequently. There are certainly other things that we could talk about, and honestly, we could talk about the rest of this topic for 3 hours. But for today, I'll just kind of go through each one, and there are references here on the bottom in case you'd like to go back to any of the primary manuscripts where these relationships were described. So dairy is one of the things people ask me about a lot. Is dairy okay? Some people think dairy is inflammatory. Some people think it's bad for general health. Some people think it's bad particularly for MS. Most of the things we're going to talk about today have not been really well studied and have not been studied in an interventional way. But so the data that I'll show you is really observational. So there was an older study that looked at T cell reactivities, so cells, in our immune system, which are highly important in MS. And they showed that T cell reactivities in MS patients showed these very high responses to milk antigens. And in particular, one of the proteins in milk. So people also ask about the fats in milk and whether, okay, maybe whole milk is not good, but maybe skim milk is okay. But one of the points made is that perhaps it's actually not the fats and maybe it's one of the proteins. So the milk protein butyrophilin has actually been implicated as possibly inflammatory in MS because there's this thing that's called antigenic mimicry, which just means that people think that protein actually looks similar enough to myelin so that the immune system maybe is being revved up against myelin inappropriately. There's also the idea that it's inflammatory in terms of the changes that it causes to the microbiome. Again, we don't have a clinical trial that really shows us an answer to this. So, I think what we have is kind of mixed. And if you look at registry studies that, when you ask people how much dairy they eat and you look at their level of disability and stuff, it's really been quite inconclusive. So I don't think we have great evidence for this at this point. One of the topics that also comes up a lot is fats, and we'll talk about some of the different kinds of fats out there and how those play into foods. So when we talk about classifying fats, we think about saturated fats, and that's called a saturated fat because the carbon chain for the fatty acids is saturated with hydrogen atoms, versus polyunsaturated fats or monounsaturated fats, where the fatty acid chain does have one for monounsaturated or some for polyunsaturated double bonds. And of particular interest for MS, people have thought a lot about omega-3 fatty acids. So that's one of the polyunsaturated fats. So what evidence do we have? So in terms of clinical studies, people have looked a little bit at saturated fat. I'm sure a lot of people are familiar with Dr. Roy Swank and his studies. So Dr. Swank really was quite a pioneer in studying diet in MS. He was looking at this before anyone thought it was a hot topic. And the research that he did, I think, was really impressive for the length of time that it went on. Unfortunately, the way the study was designed was really before the modern era of clinical research. So there are a lot of biases introduced there and make it pretty hard to interpret the results or to take them rigorously, because he didn't, for example, randomly assign people to the two groups. He just kind of told everyone, eat this diet. It's a very low saturated fat diet. And then he followed people to see what happened. And so people kind of self-selected. He called the people who followed the diet good dieters and the people who didn't bad dieters. And he found significant differences. First of all, he found that the people who followed the dietary recommendations lived longer, which is not surprising in terms of what we know, things like heart disease and stroke. But he also found that the people who followed the diet well were much less likely to be severely disabled in terms of their MS at the end of the very lengthy follow-up period compared to people who did not follow the diet well. There was also a prospective pediatric cohort study, actually led by Dr. Walbant. We mentioned earlier in terms of the pediatric cohorts that she follows. And so in this study, they had 219 children that were followed for an average of about 2 years. And what they found in that study was for every 10% increase in energy intake from saturated fat, the risk of having an MS relapse was increased 3 times. So that's huge. It's really quite large. Again, this is observation, but it's quite a large relationship. In terms of polyunsaturated fats, these are fats that are found in things like fish, walnuts, flax seeds, and in animal models, polyunsaturated fats seem to have important effects on immunomodulation, neuroprotection, also remyelination and repair. But then when we get into clinical studies, we haven't had any clinical trials specifically looking at PUFAs. There have been some observational studies, but again, the results have been kind of conflicting. So there was one study, the Nurses Health study, which suggested a link between MS, the incidence of MS, so whether or not you develop MS, and the intake of a particular PUFA. But then some other studies have showed a link between intake of fish and omega-3 fatty acids, but not clearly the ALA that was shown in the Nurses Health study. So again, I think we have some conflicting results and supplements. I think the trials have just really been too small to conclude anything. Fruits and vegetables, I think, is an important category to think about. Definitely something I highly recommend for my patients to watch. We think that fruits and vegetables are helpful through a few different mechanisms in MS. One is they are high in fiber. And we talked a bit before about the gut microbiota and how the gut microbiota produce different metabolites depending on what gets put in. And so when you put in fiber, that induces the gut microbiota to produce these short chain fatty acids. And we know that short chain fatty acids, we think they're of high benefit. They're very anti-inflammatory, for example, and they help T cells grow up to be more regulatory anti-inflammatory T cells. We also think they're important because of the flavonoid content. So that's, the flavonoids are the pigments that give fruits and vegetables their bright colors. And we think that those flavonoids have important effects on, again, on immunomodulation, as well as on neuroprotection and repair, at least in animal models. There's a very nice example of some work that was done by some of our colleagues in the past few years, which showed that tryptophan, which is derived from the diet. Specifically, they were thinking about cruciferous vegetables like broccoli, cauliflower. It actually can be broken down into metabolites that can get across the blood-brain barrier and have important effects inside the brain. So the fact that they were able to actually show that something was going from the diet to the gut, to the bloodstream, across, and then they were able to demonstrate an effect on important cells in the brain, I think it's just such interesting work, and it's so important for us in terms of thinking about the ability of diet to have effects in people with MS. Going back to Dr. Wamont's cohort, in their pediatric study, they found that a 1 cup equivalent increase in vegetable intake decreased the risk of relapse by 50%. So for people who are familiar with some of the medication trials in MS, a lot of the medications that we're really excited about decrease the risk of relapse by 50%. This is not a clinical trial, it's an observational study, but still, when you think about the numbers, it's pretty impressive. There was also another registry-based study that found a link between a higher intake of fruits and vegetables and patient-reported disability and disease activity. So I think this is one that a recommendation that most people can get behind, even if we don't have clinical trial evidence. Grains and gluten is something that people ask about all the time, and it's actually one of the areas where we have the least evidence in MS. The studies that have been done have been really small and just not really well designed. Interestingly, a NARCOM study, which was done by my colleague, Dr. Fitzgerald at Hopkins. People may be familiar with NARCOMS as a huge MS registry, which is a wonderful research resource. And thank you to any of you who participate in it. There was actually an association between higher intake of whole grains and a lower level of MS-related disability. One of the things that might be important is, grains that are high in fiber. So whole grains, we think that they may be beneficial, again, coming back to the short chain fatty acid production idea from the microbiota. Salt is something that also has gotten a lot of attention in the last few years because of some research that had come out. So we know that having a high salt intake induces the development of some of these pro-inflammatory T cells. So the T cells that grow up in the gut and can differentiate into different types of T cells are more likely to become pro-inflammatory T cells if they're raised in a high salt environment. And we see this in animal studies. There was a study done by some of my colleagues in Argentina that looked clinically, and again, this is observational, it's not a clinical trial, but they looked at 70 people with relapsing MS and they stratified them by their sodium intake. Those who had a medium or a high level of salt intake over 2 years had a higher relapse rate and a higher number of new T2 lesions on MRI. However, there have been some additional studies that just haven't confirmed this from an observational standpoint. So Dr. Wallman's study, they looked at their cases of pediatric MS patients compared to those who didn't have MS. They tried to use a food frequency questionnaire to estimate sodium in the diet. They didn't find a link. And then, looking at people with established MS, again, pediatric study followed for almost 2 years, didn't find any link between the relapse rate and sodium intake by food frequency questionnaire. And then my colleague, Dr. Fitzgerald, again, looked at the benefit trial data. This was an older study that was a trial for interferon, but they had banked urine samples. And so they were able to estimate the salt in the diet by looking at the urine samples. They had over 400 patients in that trial. They were followed for quite a long time, and they didn't find any link between salt and clinical relapses or MRI. So that's a big question mark. Okay. So let's look now at some of the different patterns, and I'm sure people have different experiences with these. So there are a lot of different MS diets that are popular. The questions that I get are, well, I see all these different diets out there. They're all different from each other. Which one is the right one? And then the question I ask back is, well, what's the evidence? Okay, so let's go through some patterns. So first is just thinking about overall quality of the diet. And this slide has some information. And again, I put these here so that if people are interested, they can go back and look at these papers. But the punchline here is really just that there are 2 separate registry studies that showed a clear association between overall quality of the diet, which is established by using a dietary screener and assigning points for different items. The overall quality of the diet does seem to be linked to MS-related disability. And this is all self-reported scores, but I think very interesting and important nonetheless. So some of the patterns that people have been looking at, we talked briefly about the Swank diet. Other patterns people are looking at are modified Paleolithic diet, or also known as the Wahls protocol, McDougall diet, which is a plant-based, very low-fat diet, caloric restriction and intermittent fasting, ketogenic diet, and then our group has been studying a Mediterranean or MIND type diet. We'll just go very briefly through each of these. Basically, what I'll tell you is that for each one of these diets, my colleagues have done a great job moving the field forward, but all of these studies are kind of small and pilot size, and hopefully over time, we're going to be able to do larger, more rigorous trials to really learn. But what we've got so far is a little bit of evidence. So first, I'll just tell you briefly about the Wahls. People know this as the Wahls diet and the WAVES trial. This was looking at a Swank diet versus a Wahls diet. The Wahls diet, people I'm sure are familiar with, is a Paleolithic elimination diet, which includes meat, fish, certain vegetables and fruits, but eliminates entirely gluten, casein, and lectins. And in this study, there were 87 participants who had significant fatigue at the beginning, who were randomized in a 1-to-1 fashion. They were followed for 24 weeks, and they did very well. People had significant reductions in fatigue when following this dietary pattern. The McDougall diet is based on the intake of starchy plant-based foods. Only 10% of energy intake is from fats. There's no animal products at all or oils allowed in this diet. My colleague, Dr. Yadav, at OHSU led a study where they randomly assigned 61 people with MS to follow this diet or to be a waitlist control for a year. The primary endpoint of the study was looking at MRI, and they did not meet that endpoint, and they didn't find a difference in clinical relapse rate. But honestly, the study was really too small to be able to tell those things. I'm sure people who are familiar with MS clinical trials will know that we enter hundreds or 1,000, patients into those studies. So this study was really quite small to be able to look at those things. What they did find was that this diet significantly reduced fatigue. And so that was very exciting. As we know, fatigue is a huge, huge issue in people living with MS. And so this led them to design a larger study, which is completely focused on fatigue, looking at this diet, which they're doing now. Caloric restriction, intermittent fasting, very hot topics, not only in MS, but in the general health world too. So there are a couple different ways that people can do this. We know that chronic calorie restriction is of benefit in animal models, but that's not really, I think, a reasonable thing for people to do all the time. What people have really looked at is this, idea of intermittent fasting or a fasting mimicking diet. The idea is to try to get benefits of fasting without having to fast all the time. And we can see from animal models that there are beneficial effects on immune modulation, protection of oligodendrocytes, and promotion of repair. An initial study in people with MS showed that people were actually able to follow these patterns. It was a pretty small and short study, but it seemed like people were able to do this. It was pretty well tolerated. They lost a little bit of weight and they had improved emotional well-being. So we'll see where that goes. Ketogenic diet is another pattern people are interested in. The idea behind a ketogenic diet is to shift metabolism. So the idea is to use fatty acids as the primary energy source. And that leads to production of something called ketone bodies, which lead to a decrease in pro-inflammatory cytokines, the way that the immune system communicates. We know that ketogenic diet seems to be of benefit in animal models in MS. And there was recently, there actually were one study and then a follow-up study done. The newer one was an open label study, so everyone knew they were getting the ketogenic diet, which is, the way it has to be. But it was a single arm study without a control group. But it showed that the ketogenic diet was pretty well tolerated, associated with some weight loss and improved body composition, and again, helped with fatigue, also helped with depression, and seemed to at least stabilize, maybe actually improve even a little bit MS-related disability over at least in the short term. So now I'll actually spend a few minutes telling you a little bit about why our group has focused on Mediterranean style diets, and I'll tell you a little bit about some of the work that we've published recently. So the reasons we've been interested in this type of diet are several. First is there are very well-established general health benefits for this type of pattern. There's great data in cognitive aging, so we know that Mediterranean style diets are helpful in terms of prevention of development of dementia or slowing of dementia. And when you think about MS and neurodegeneration in MS, it's different than that in Alzheimer's, but there are a lot of similarities actually. And so we thought that was a helpful starting point. This pattern combines the limited information that I told you about in terms of components that we do have. I think that this pattern kind of encompasses all of those things. We also feel that it's reasonable to aim for long-term adherence. So this is really a lifestyle change rather than a diet. It can be very friendly for the household budget. And because it's something that's really good for general health, it's something that everyone in the house can do. So it's not, something where it's like you're the person who has MS and you're going to be the only one in your house eating this way. This is something that the whole house can do. And then I'll tell you a little bit about the evidence that we have in MS. So this was a pilot study that we ran a few years ago where we randomly assigned 18 patients with MS to follow this diet and 18 to participate as a control group. And mostly we were thinking about feasibility. So the study was going to be run for 6 months, and we really asked people for a big commitment. We were worried about whether people would volunteer and how the participation would go, but I'm very pleased to say that the recruitment effort went great. Everyone who participated did a fantastic job in the study. What we found was that the people who were on the intervention part of the study lost a small amount of weight, about 1 pound a month, even though we didn't ask them to lose weight and we didn't counsel them on calories. It was just from improvement, I think, in terms of the foods that they were eating. And we found benefits in the intervention group compared to the non-intervention group, again, in terms of MS-related fatigue, the impact of MS symptoms on daily life by a common questionnaire that's used often in MS, as well as on their disability score. So we were really excited about this. The next thing we said is, okay, now we need to work on some more background evidence to show us that really this is the right path. And so we started thinking about, well, how can we get that kind of evidence to help us build a large clinical trial? So we said, okay, we got to do some observational studies. So next we wanted to look at imaging, and I'll tell you how we moved into that. But we thought about different patterns. We like what's called the MIND pattern, which is Mediterranean Dash Intervention for Neurodegenerative Delay. It was initially developed by colleagues at Rush University for people with Alzheimer's and in cognitive aging. And the MIND diet, when you're assessing someone's diet and you want to assign a score, you give a score of 0 to 15 and people get points for different things. So here you can see in blue that there's a score that's based on, quote, healthy things we think are going to be healthy for the brain. And then in pink, the things we think are going to be unhealthy for the brain. And so everyone gets a score. Our idea, our hypothesis was that we think there's a benefit to this diet in terms of neurodegeneration in MS, in addition to the immunomodulatory benefits. This is what we wanted to study. So the first thing we did was we have a cohort of people who volunteered to be part of research when they were within their first few years of MS diagnosis. And we have 185 people in this cohort. We are now in year 6 of follow-up of this cohort, and we're learning just so much from it. But this paper that we published was based on the baseline data when people first enrolled in the study. And we had them all fill out a food frequency questionnaire so we could understand their diet. And we assigned everyone a score, a MIND score between 0 and 15. And then we looked at the volume of their thalamus, which is a deep structure, which is actually the first structure in the brain in MS that gets affected. And so even though people were in their 30s and only 2 years on average from the time that they were diagnosed, what we found was a link between their MIND diet score and the volume of their thalamus. So the more someone's diet aligned with the Mediterranean pattern, the better their thalamic volume was. And thalamic volume is linked to all kinds of things later in the disease course in terms of brain volumes in the rest of the brain, as well as clinical disability. So this was pretty exciting for us. The next thing we did was we wanted to look clinically to see in terms of like physical issues and cognitive issues and to see whether those were related to diet. We couldn't do that at that point in terms of the first cohort that I just showed you with MRIs, because those were people who were only really 2 years from diagnosis. And fortunately, they really didn't have a lot of physical or cognitive issues. Some people had some, but it wasn't enough to be able to study something like diet at the baseline. We'll be able to do that over time. So what we did was we looked at our cohort of people with MS who've come through our comprehensive annual assessment program. We have a program at our center that we encourage everyone to come through, and it involves a set of assessments every year. And it's all kinds of stuff, language and memory testing and physical testing, questionnaires. And what we found was a very nice relationship between the Mediterranean diet score, we used a screener, and the MSFC, the multiple sclerosis functional composite, which looks at, people will be familiar with a 9-hole peg test, how fast you can put pegs in a dish, a timed 25-foot walk, how fast you can walk 25 feet, and the symbol digit modalities test, which is a quick cognitive test. And we found this relationship after we controlled for all of these demographic and health-related variables. So we controlled for age and sex, race, ethnicity, socioeconomic status, body mass index, moderate to vigorous physical activity levels, sleep, hypertension, diabetes, high cholesterol, and smoking. And after we controlled for all those factors, there was still a relationship with Mediterranean diet score. So we thought that was pretty interesting. Similarly, we found a relationship between this score and all of the patient-reported outcomes, or PROs, that we administered. So we asked people questions about their fatigue and their MS symptoms and their walking and their cognition and depression. And we found they were all seemed to be related to people's dietary habits. Okay, so where do we go from here? We're going toward bigger clinical trials, and we're all trying really hard. The biggest barrier is really funding, but we're working hard to move this field forward. So the question at the end of this is, where are we now? What can we recommend right now for people living with MS? So I'm very fortunate to be part of a fantastic group of people at the National MS Society's Wellness Research Working Group, and we have a nutrition subcommittee. And all of the studies that I just showed you are people who are really interested in diet and MS, and we all work together and meet every month. And so there are some recommendations that we all agreed upon, and these are the tenets right here, and they're posted at the National MS Society website. But the things we all thought we can agree on now and that we recommend to our patients are, as much as you're able to, try to prepare meals at home, incorporate colorful fresh fruits and vegetables every day. If you do choose to eat grains, you should try to choose whole grains over refined grains. And really my biggest recommendation to my patients is to try to avoid or limit processed foods and added sugars as much as possible. In terms of getting started, these are just a few of my clinical recommendations. The first is to think about your goals. What do you want to do in the short term? What do you want to do in the long term? Another is to include your household in your plans. So, I mentioned before, the thing I love about Mediterranean patterns is it's something that everyone in the house can do. It's not like you're making one meal for yourself and then, another meal for everyone else in your house. This is something that everyone should be able to get on board with. It's healthy for everyone. And the more you're able to do that, the easier you make it for yourself, the more likely it is that you actually are going to be able to do the things you set out to do. Another recommendation is that you should aim to make some positive changes that are really going to be just incorporated into your lifestyle. It shouldn't be a diet. A diet is something like, our parents did for a few months when they went on Jenny Craig or, whatever else they did, but it was not sustainable. The idea is to just make some changes that you think can just become part of the way that you eat instead of looking for, a diet. Practice makes progress. So it's not going to be perfect. And it does get easier over time. Asking for help, I think, is really important. So you can talk to your primary care doctor about this. You can try to arrange a visit with a dietitian. I think if that's accessible for you, it's a wonderful thing to do, but it can be hard. There are some insurances that will reimburse dietitian visits. Not all of them do. But if it's something you're able to do, I think it's great. You can also ask at your MS center if there's a staff member who's able to counsel people about diet. So I am, of course, very comfortable with this. This is my area of research. I'm always happy to counsel my patients. Not every physician is going to feel comfortable with it, but there might be someone else in the practice who is. There may be a nurse practitioner who has an interest in this, or there may be just someone else in the practice who has an interest in this who might be able to work with you. And the last thing, the most important thing, is to be kind to yourself. So this is not something to be anxious about or to feel badly about. The idea is just to make a little bit of progress here and there so that over time you get yourself into as healthy of a pattern as possible. I'll finish by just telling you that we are very fortunate at our center to have developed, I co-direct this patient wellness program with my nurse practitioner, Gretchen Matthewson, who's wonderful. And we have a fantastic team of people we work with. So we're very lucky to have this patient wellness program. Our biggest issue is not having enough resources to be able to run it in the way we'd like to be able to serve everybody, but we're trying. And we're hoping that over time, if we're able to show over time through research that this program is effective, we're hoping to be able to get insurance reimbursement for it and to be something that's accessible to everyone who lives with MS. So just to conclude, we have strong scientific rationale for our interest in the role of diet. We have limited evidence at this point for a role for particular factors and patterns on outcomes. General principles of healthy eating we think are reasonable to recommend now. And with that, I will thank all of the wonderful people that I work with, the MS Society for funding our work, all of my patients and their families for putting up with our constant requests for participation in research. And you guys get to see my crew at home of little helpers. So thank you so much for your attention.
Thank you so much for your presentation, and your helpers are gorgeous.
Thank you.
I don't know how you got the freedom there.
I do. There is quite a bit of noise on the other side of the wall. I hope you guys are not doing anything.
We got a few questions, and I know we're running over. Sorry, Dr. Bowen. Sorry. So let's see here. Is there any research that explores how DMTs themselves might interrupt the body's ability to absorb and utilize nutrients that actually help with MS? Thanks for your presentation.
That's a great question. No, there has not been any research specifically looking at that. I would not expect disease-modifying therapies to interfere with the way the body absorbs nutrients. The little bit of work that we've seen so far seems to suggest that the disease-modifying therapies seem to push the gut microbiota in a healthier direction. It's very little bit of research that's been done so far. So my guess is, if anything, the disease-modifying therapies that we have seem to be making positive changes on the peripheral immune system that may actually make it easier for a diet to be effective. That's my guess, but that's a guess.
I think you kind of answered this, but your opinion on a plant-based diet for MS?
Yeah, I think a plant-based diet, is great for general health. I definitely recommend something that's mostly plant-based. People have different preferences in terms of whether they eat meat at all, and I think we don't have enough evidence to say for certain, all meat is bad. For example, I did present some data on saturated fats, for example, which mostly come from animal products. So we do have some links there, but I think the data are not definitive enough to say, oh, definitely this is the way to go. But I think it's a good thing to do. It's very good, certainly very good for general health. It's good for the environment. It's, so I do like a plant-based diet.
Does the high use of pesticides, i.e. glyphosate, affect MS?
It's a great question. We don't know that for certain because it's a very hard thing to study, as you can imagine. There's been a little bit of work looking at pesticides like in animal models and, basic science research, but it would be very hard to design a clinical study to look at that. As you can imagine, people have all kinds of different exposures. I do recommend, I think for everybody, but I do recommend to my patients that when you're able to buy products that are organic and local, if you're able to, if it works in your budget, and a lot of this you can do best by if you have like farmers markets in your neighborhood and things like that, I do think it's better to try to avoid these pesticides. I think they're not good for us. Definitely everyone should be properly washing their produce before consuming them. It's more of an issue for produce that don't have thick skins, where you're not, when you're peeling something and throwing that, and then you're eating the fruit or the vegetable that's inside. I think it's probably not as big of an issue. But I think in general, pesticides are not good for our health, the same way that so many things that we're exposed to every day, air pollution, plastic containers, all these different things I think are not good for us. Whether they're specifically bad for MS, we just don't know, but I would guess they probably are.
What is your thought on parasitic infestations within the body as a cause of MS or activator of MS symptoms?
Parasitic infections. We haven't found any evidence for parasitic infections. Parasites are interesting. People actually have studied a little bit the idea of actually purposefully giving someone a parasite to try to help with MS, just because certain parasites actually can induce a state of immune tolerance in the gut. And so there are some people who think that this is like a helminth, that we should actually be looking at these to try to help promote immune tolerance in MS. But there hasn't been anything that I can think of, any data that I've seen to show particular, I don't know if there was a particular parasite that someone had in mind, but parasitic infections are also just not that common, in the United States, for example, maybe, more common in other places in the world, but mostly in places where they have a lot less MS than we have here.
What does the registry mention that I could join to be included in dietary studies?
So that's a good question. There are actually so many different ways to be involved. The registry I was mentioning was the NARCOMS registry, which is run by CMSC. But there are many other studies that people can sign up and volunteer for if you want to be involved. Yeah, there's MS PATH. There's all different ones. I would definitely encourage speaking to your physician about it. They could recommend one that's local to you or one that you could sign up for online. But thank you for volunteering.
Thank you. I think there's some other specific questions. Maybe I could email you and then we could get the answers back to them on those.
Sure.
Great. Thank you so much. Thank you
for having me. Thank you.
Your gorgeous helpers behind you.
Thank you.
Thank them for letting us have you for a brief portion of your day.
I will. They were pretty good. Thanks, guys.
Namaste. This is such an important topic that does get so many questions.
Yeah. Thank you.
All right. We are definitely running late here. 1 minute video just to break this up. And George is coming on. It's a 1 minute video similar to Stacy, but everybody's got an MS warrior story to tell. And how cool that was that Stacy works with Alana.
We're gonna have MS. We got diagnosed with MS. There's nothing we can do about that, but we can do a lot about our attitude, how we react to it, the choices we make, how we live our lives. I have this acronym, AID, attitude, diet, and exercise. I get a lot of times, I get pissed off, I get frustrated, but I get over it. I put it aside and say, okay, you know what, it sucks, but life goes on. My attitude is going to determine how I live my life and everything. It's so important to eat healthy for anyone, especially if you have a chronic illness. So see what works out for you. Eat and see how it makes you feel and what diet works for you. And then the last one, exercise. For me, for right now, it was yoga. Before, it was lifting weights. So it doesn't matter if it's swimming, if it's tennis, bike riding, find something. It's not just yoga, it's like an additional support group. Accept that we have the disease, just adapt and achieve.
Thank you so much, George, for sharing your story. Thank you to our sponsors on the screen and getting ready for our keynote. He's been with us all day. Thank you so much, Dr. Bowen. We're very excited, and Dr. Belkin is going to introduce you. And this is just a great way to cap off the day with your presentation, with your ideal, really optimal model, comprehensive model. I had no idea it existed, and so excited to hear about it from you.
So great. So they've been great lectures. Mindy, you and your team have done an amazing job today with this lineup. And certainly now we have our keynote speaker, James Bowen, MD, is medical director for the Multiple Sclerosis Center at Swedish Neurological Institute in Seattle. In addition, he is a clinical professor in the Department of Neurology at the University of Washington. He has served in many capacities with the National MS Society, serving as the Society's Hall of Fame for Health Professionals and Researchers Award in 2005. Dr. Bowen has published more than 160 peer-reviewed journal articles, plus numerous book chapters and abstracts with an emphasis on multiple sclerosis. His research focuses on clinical trials in MS, including hematopoietic stem cell transplants. Dr. Bowen was instrumental in creating the MS Center at Swedish that is internationally recognized as a model for providing comprehensive care of patients. Dr. Bowen will present about the Comprehensive MS Center at Swedish Neuroscience Institute, their unique wellness program, and how they optimize wellness, which is divided into 3 parts: physical, emotional, and community. An extensive list of wellness opportunities offered at SNI will be discussed, including but not limited to traditional medical care and support groups, vocational services, yoga, Pilates, music therapy, movie club, creative writing, and adventure guide program for activities such as snowshoeing, cross-country and downhill skiing, and skydiving. Dr. Bowen will discuss how programs can be initiated in other communities. So without any other delay, Dr. Bowen.
So give me a thumbs up if you're able to see my slides.
Yep, your beautiful mountains. Is that where you live?
That's where I live. This is Mount Shuksan, just north of Seattle, about 2 hours. It's actually the most frequently photographed mountain in the United States. So that's very beautiful. Today I'm going to talk to you about our program. And we have, of course, a comprehensive MS program that involves medical care. We have a robust research program. But today I want to concentrate on our wellness program. First, I have to figure out how to get my slides to advance.
Hold on, Dr. Bowen. I'm not sure why we're not hearing your sound.
That's because I'm trying to get the slides to advance. They're not not reacting.
Hold on 1 second.
We may have to switch. These are mine on, I'm sharing my screen, but maybe we can switch. You have the slides and perhaps we can just switch to your version and then we'll advance them from there.
She's switching them over.
All right. That's good. So first I thought we would talk about how we as physicians define our patients. One way to do it is the pathology. For example, they have MS, periventricular lesions on their MRI. The pathology of this is that it's an infiltrate of lymphocytes and macrophages, and that this is due to a dysregulation of the immune system with all the complex pathways of immunity. We also define our patients by their disease course. Do they have relapsing remitting disease, or primary progressive, or secondary progressive? Or what is their level of disability? The scale we use most commonly is the Expanded Disability Status Scale, or EDSS. We also think about patients in terms of how their MRI is doing. Is the MRI stable, or does it have new lesions or new enhancing lesions since the last time we saw them? We also think about them in terms of what treatments they're on. Fortunately, today we have 18 therapies, and perhaps by the end of the month there may be 19. But these involve injectable therapies or oral options, and also intravenous options. So we define our patients as physicians from a number of these medical aspects. But how do our patients define themselves? It's certainly not anything that I mentioned before. They really define themselves in things like their family and how they fit into the family dynamics. Are they, a person that's providing food for their family? Are they participating in family activities? Things like that. They also define themselves as part of their jobs. And are they a physical type job, or are they bringing in a lot of money to support the family, or are they define themselves by the intellectual contribution they do to their job? Another way they define themselves is by what they do with recreation. For example, are they outdoor enthusiasts? Do they enjoy travel, theater? Do they enjoy music or crafts that they do themselves? Or are they more into literature? So when a disease like multiple sclerosis tears the fabric of a person's life apart, how do you put that back together? Ideally, we would just fix the disease and repair all the damage that it's done. But with a disease like multiple sclerosis, we do not yet have that ability. We can slow the disease down with our therapies, but we can't repair the damage. So sometimes the best that we can do is to take pieces of what used to define these people and then build on that, what remains, to try to rebuild some of what the disease has taken away from them. Looking at definitions of health and wellness, there's on the left side the definition by the World Health Organization, which says that health and wellness is a state of complete physical, mental, and social well-being, and not merely the absence of a disease or infirmity. On the right-hand side is what our MS Center defined as wellness. This is physical, emotional, and community wellness. In our group here came up with this definition about 15 years ago. And then about 10 years ago, I realized that the World Health Organization came up with this in 1948, and that we had somewhat reinvented the wheel with just slightly different wording. But I will move forward in the talk by going through each of these three areas individually. The first is physical wellness. I think this one is the simplest to define. We have a number of resources within our clinic to help support people from a physical wellness standpoint. We have a rehabilitation physician who is MS fellowship trained. We believe there's only 7 or 8 of these in the United States, so we're fortunate, but in your local communities, you probably have rehab physicians that do have experience with MS. We have a physical therapist and an occupational therapist that are specific to MS. That's all they do. Our physical therapist in particular works with our patients to custom design exercise programs for them. If they live close to our clinic, before COVID messed it up, we had open gym 2 days a week, so our patients could just come in and they could use our facilities. These include a lot of exercise equipment for people with disabilities. A lot of patients, our catchment area includes Alaska and all of Washington State, northern Idaho, and western Montana. So a lot of our patients are out there a ways and they can't come to our clinic twice a week. So we also develop exercise programs for them that they can take back to their local communities. Also, as part of this, we have 2 yoga classes a week, and there's a quote on here: "My physical challenges include stiffness from spasticity balance problems, and muscle weakness. So I appreciate the flexibility, stretching, balance, and strengthening exercises. I also use the breathing exercises, meditation, and relaxation activities to help manage stress and blood pressure. We also offer 2 Pilates classes a week. Mary here says, I must tell you, Pilates are the best workout for us. Everyone in the class is always talking about it. We all are constantly telling others how beneficial it is. And then she goes on to say, sorry, but I have to spread the knowledge. You don't really realize how great the exercise is until later that day or even the next day. We're working parts of our body that have been asleep for a while, and that is so important for our stability. I want to point out also on the right-hand panel of this slide, lying on the floor is Phoenix, the dog. I think Phoenix is in the wrong class. Phoenix attends the Pilates classes, but Phoenix should be in the yoga class because Phoenix really has the down dog pose, has got that figured out in this picture. Moving on to emotional wellness, we have a rehabilitation psychologist that specializes well, really only in people that have multiple sclerosis, but they are trained to treat people with chronic diseases and all of the difficulties that come along with that. We have 1 or 2 psychology interns every year. These are people that are finishing a PhD in psychology, and they have to do a 1-year internship. They are not licensed yet because they have to finish their internship first, but as a result, they do not bill for their services, and we're able to offer intense, frequent psychology counseling for free because of their presence in our clinic. We have a neuropsychiatrist to help with medications for emotional wellness. We have a social worker who is able to provide counseling. About 3 or 4 times a year, we offer workshops. Most of these are 6-week sequences with about once a week meetings. And some of the areas that they've had workshops on include relaxation and stress reduction, pain or fatigue. We have 4 traditional support groups. One is an MS club at Cherry Hill. Cherry Hill is the neighborhood of Seattle that our clinic is located in. We have a support group for care partners. We have one of the few LGBTQ support groups for MS in the country. And then we have a neuromyelitis optica support group. This picture is the MS Club went to one of the Mariners games. You can tell this is a few years ago because they're all smiling. It was a year that the Mariners were actually doing well. Although this year they did go to the playoffs. So hopefully we'll have more happy Mariners attendees in the future. The last area is community wellness. This is an attempt to enhance community or get people re-involved in kind of normal life activities outside their home. We have a social worker, as I mentioned before. We also have a vocational rehab counselor, and I believe she's the only person in the world that all she does is multiple sclerosis vocational issues. About 2/3 of her job is to help with workplace accommodations, including going out to the employment, the place of employment, and working through with the employer what appropriate accommodations might be. And then about 1/3 of her work involves patients that need to go out on disability. We have the rehabilitation psychologist, as I mentioned. We also have neuropsychology. These people do neuropsychological testing to document cognitive impairments. We have a couple of get-togethers. This is pre-COVID, and we hope to be able to bring them back soon. One is an annual summer barbecue that's held at our facility that's catered. We usually have about 100 to 150 patients coming to that. We have an annual holiday party with music and food, and we do free gift wrapping that our staff volunteers for, and some holiday-related crafts that patients can participate in. Then we have some areas that we thought about, sort of that slide earlier on about how people define themselves with their recreational, what they do for recreation. And one is music. We have 2 music therapy classes a week, and many of you met Betsy as the first speaker of the day. She's one of our 2 music therapists. They also do one-on-one sessions, and often in conjunction with our physical therapist, where they use music to entrain things like gait and other exercises from a physical therapy standpoint. So we combine efforts. We have taken groups of patients out to concerts. We had a neuro tango, which is tango dancing everywhere from able-bodied people to people in wheelchairs. And then we have a Get Back Your Music program, which I'll discuss in more detail in a few slides. These are, this is a picture with Betsy and some of her music therapy programs. She gave you an entire talk on this, so I won't go into too much detail. Dorian here says that music therapy at the Swedish MS Center has helped me to focus, center, and take care of my well-being, not just physically, but emotionally and mentally. A group program provides a unique setting for joining others with MS, providing a community support as well. The one-on-one sessions have helped me process a lot of changes that have taken place, both good and bad. This is the Get Your Music Back program, and this was started by the guitar player, the man there in the baseball cap. Phil is a professional retired blues and rock guitarist who got bored with retirement and decided to start this Get Your Music Back in our clinic. They are a group of these 4 are a group that have started a band called Axon, and they play at our barbecue and our winter events, but they will also give free lessons to people with MS. And right now they have a acoustic guitar, classical, electric guitar, a bass, electronic drum set, a Yamaha keyboard. We also have a Kawai grand piano, and they will offer free lessons to anyone with MS who wants to come and get their music back. This, many slides forward. This is a quote from Patty. Patty is a professional drummer and was actually inducted into the Pacific Northwest Jazz Hall of Fame a few years ago. Anyway, she said, when I first heard of the program and met Phil, I had basically come to the conclusion that playing drums is pretty much over for me. It was perhaps one of the most distressing aspects of my personal struggle with MS. It just seemed so unfair that this skill I had developed over the past 45 years or so was just fading away. The folks who had been paying me to play with them for many years seemed to be falling off the radar as well. After a few sessions with Phil, however, I started to feel all was not lost and began really looking forward to jamming every week. Soon it really became like a lifeline, something that made me feel sane for a couple of hours each week. Something that was still under my control. I just felt like a musician again. We also have art programs, and we have an annual art show pre-COVID, which again, we plan to bring back as soon as we can start meeting in large groups. We've taken groups of patients to art centers to do art glass the Frye Art Museum for a tour not only of the art in the museum, but meditation and mindfulness workshop, glass fusion, making holiday ornaments, adult coloring and craft group, and jewelry making. This is a picture of the art show. The white walls are covered with art by people touched with MS. There's about 200 to 250 art pieces that are displayed in our art show. Some of them are from family members, such as children. Some of them are more just directly related to MS. Some have nothing to do with MS. And then some are just in your face about MS. This patient that made this MS sucks slide actually wanted to withdraw it because she thought nobody would like it, but it turns out to be extremely popular with our patients. And then one of the most unique, probably the most unique offering that we have, we had to come up with a name for it, so we came up with Adventure Guide. And our purpose of the Adventure Guide is keeping all people with MS engaged in joyful life experiences through fun and challenging events. We've been doing this for 6.5 years, since 2016. This is the offerings that we did the first year. And basically the Adventure Guide is arranging field trips for people with MS to get them back out there doing things that are fun. Simon, who is our occupational therapist, is the one that runs this program. This first year he had indoor rock climbing, sailing in Puget Sound. They had an event for adaptive cycling where people with paraplegia or balance problems they have different types of cycles that they can ride. Horseback riding, including paraplegic patients, that they have a lift to get them onto the horse. Adaptive kayaking, again, with lifts to get people that are up to quadriplegic levels of disability back out there doing things. Crystal is a downhill ski area, and in the summer you can take the gondola up, and there's a paved trail that you can go wildflower, look at the mountain wildflowers. This is a snowshoeing event, and then he does adaptive skiing, including a sit ski that a quadriplegic patient can steer. If you can move your head, you can steer the sit ski. Adaptive table tennis. There was an introduction to scuba, an introduction to archery, and they did indoor skydiving, which is a vertical wind tunnel that will take you up into the air. And then they did rafting. That was the first year. These are some of the other events that they have done since then. Their self-defense courses, Neuro Tango, the sailing in Puget Sound. They've added overnight camping on one of the islands in the Sound, and again, including people up to quadriplegic patients. They have done tandem paragliding, the iFly indoor skydiving. They've gone to many concerts, several local speaking and book readings that have been given. They've gone whitewater kayaking, airplane flights over the region. They've attended the ballet, hot air balloon rides. They've gone to the circus. They did blacksmithing, where you can make your own blacksmith art, and they have blacksmith assistants that if you're not strong enough to beat on the piece of metal yourself, you can tell the assistant where to beat on it for you. Various professional sports groups, Mariners, the Sounders teams, comedy theater, indoor rock climbing, creative writing workshops, rafting, And then during the pandemic, many of these we could not do, but we moved on to virtual reality headsets and have posted a lot of our adventures that were recorded with a 360-degree GoPro and turn them into virtual reality adventures. So you can go rock climbing, for example, from your chair in your living room. A few other things, theater, we've gone to Broadway musicals, speakers. Cirque du Soleil gave us 56 free tickets right before the pandemic. And then since we were a group, I had many of the performers meet with our patients after the program. Books that were read the first year that we offered this. We have two creative writing groups, but last year the first of the creative writing groups published their own book on Amazon. I thought it was really great, and you can order it on Amazon, and it helps the proceeds from it go back to support our programs. Finally, food. The first one that we did was the Sip, Taste, and Relax tour, which we had to be careful on how we advertised this, so certain administrators wouldn't get upset. But the Sip part was a tour of the Ballard Distillery. And then from there, it went to the taste part, which was a tour of the Theo Chocolate Factory, which is located in Seattle. I have to say that the chocolate bars that you can buy in some of the stores across the country, they're good, but the really good stuff are the truffles that are in the factory itself. And then the relax part was a tour of a marijuana grow facility, because this is the Pacific Northwest after all. They've also done walking tours with a nutritionist at PCC, which is a grocery here that's a co-op and specializes in healthy foods. So that's a taste of some of our programs. And then I wanted to spend just a few minutes about like, how do we finance all of this, so that it can give you some ideas of how you might do this in your own communities. The biggest expense we have is salary support, and it runs about $250,000 a year. The 5 salary supports we need are social work, vocational counseling. We have a coordinator that coordinates all of these programs for us, the adventure guide, and then we have instructors for our Pilates, yoga, and music therapy programs. There are equipment needs, but these are generally fairly small upfront costs. And then the art show it takes some money to put on an art show, and the cost of that varies with the venue. I had the finances from 2018 readily at hand, and our adventures cost us about a little bit over $8,000, and we had 313 people participate in those. Some of these participated in more than one activity. These adventures become unofficial support groups, de facto support groups, and they often break off and become a group of self-sufficient friends that get together quite often. These programs come and go, and you'll run one for a few times, and then the people that are interested in that will break off and start doing it on their own, and then you can morph into a different adventure. One thing we learned about this is that it is really important for you to supplement the cost to the patient. We initially started charging $20 to participate in one of these, and for example, one of them, we provided transportation and lunch to drive about an hour and a half away from Seattle and go rafting down one of the rivers, and then transportation back. And we had about 2 people that showed up But once we offered scholarships to cover the cost of the $20, we, within 3 days, sold out the event. So many of these people are on the edge of their finances because of their disease, and they cannot even afford $20. So you have to take that into account. The first step, the low-cost things, you can put up support groups. You just need a space to do that. And then it's important to provide snacks for your support group. The self-limited workshops are cheap, movie club, and also some of your support groups. You need to get access to an LCD projector, a computer, and a DVD player. You can leverage your network for special interest. Most of our adventures and ideas come from our own staff that have interest in these areas. Patients and their families may have contacts that can help you. We get physical therapy and medical assistant students to help, like with our barbecues and things like that, because they need to have so much face time to finish off their degrees. And in return for 4 hours of helping us at a barbecue, the MA students get a nice letter from us saying that they participated in 4 hours. Also, yoga, Pilates instructors. We started out with volunteers that volunteered their time, and then as the program built, we were able to fund it. Community contributions, event tickets and food are often donated. I mentioned the specialty food stores, sporting equipment stores may be able to help you with bicycles and boating access. Once you get your program going, participants can help you gain additional resources like offering art classes or music equipment. Contacts within a horseback riding community really came from our patients that had an interest in that. And then similarly with various community clubs. Once you get off the ground, then you need more serious money. And some of this can come from pharmaceutical partnerships. For example, this forum that I'm speaking at was funded with display fees from pharmaceutical partners. You can also write for grants to pharmaceutical partners to try to help you. There's also many communities have art grants or corporate grants if there's a large employer in your community. And sometimes states or local governments have grants for disability to improve people with disabilities' lives. Family nonprofits are another good source. These tend to be most interested in vocational or education issues. So you can leverage those. To do so, it's important that you get a nonprofit that is either your nonprofit or you can partner with it so that people are donating money to a nonprofit, which helps them on their taxes. Within that nonprofit, they need to be able to earmark the money for your specific cause. In this case, it's multiple sclerosis. You do not want it to go just to a hospital nonprofit that you cannot retain that money for MS. You need to have an elevator pitch of what you would do if someone that you're riding on an elevator with just suddenly says, you know, I've got $1,000 that I'd like to donate. What would you do with it? So you need to think in like 1,000, 5,000, 10,000, 25, 100,000 denominations like that. Like, what would you do with that amount of money if it just fell out of the sky? Because if you just stammer and you don't know what you're going to do with it, you probably won't get that money. But if you really know what you would do with it, you very well may get it. It's easier to raise money if you have a successful program and then you are just falling short on funding because people want to donate to successful programs. So you need to get a successful program to start with. Also, start your sales pitch with stories, not spreadsheets. So you need to have examples of how your programs have changed people's lives, how that quadriplegic patient that went downhill skiing for the first time in a decade was so pumped after that it made a huge difference in their lives. And then learn about your potential donors first so that you can target their interest and align it with your interest. Funding salaries, you may be able to leverage some of this with your hospital, for example, like social worker. It takes a large amount of cash flow for this, and we aim to have a 3-year runway of funds before we hire someone. So we want 3 years of that salary in the bank before we hire someone, because we don't want to hire them for 3 months and then say, oh, sorry, we're out of money. Endowing it is the hardest piece of fundraising. Most donors like to give money and see it spent right now, and it's hard for them to conceive that it's better to just bank this money and live off the interest so that you're able to endow it perpetually. But ultimately, endowing it is a great way to go. I think I have 2 more slides. This is Ron. He is paraplegic, and we did an indoor skydiving event, and it was actually covered by the local news media. And at the end of he was the last seen on the news program, and as he slid from the bench on the side of the iFly skydiving tunnel, he slid from that bench into his wheelchair. He said, "Normally I can't even walk, but today I could fly." And that's what these kind of programs are giving back to people. This is my last slide, and I just want to emphasize that if you keep your narrow focus on what people need for well-being, like in the case of a doctor, if you just think about only their MS drug, for example, you really have a very limited view of it. But if you expand back and try to broaden your horizons, really you will find your abilities to help these people are much larger than you think they are. So with that, I will stop, and I'd be happy to answer programs or questions about our programs.
Thank you so much, Dr. Bowen. I guess my question is, are you coming to Michigan to create this program here?
Well,
and then are you going to go to all the other states and countries on, right? I think
yeah, that's I wish I was able to clone myself, but we are happy to try to help people develop these in your local communities. And local communities have different people like to do different things in local communities. Seattle is very outdoor oriented, for example. So we believe that about 40% of the MS centers in the United States have actually come to our clinic to see how we do it. And we're happy to share that knowledge with people.
I just had a question come in. Can people plan, you're going to have visitors, I think. Can people plan trips to have a limited time with you? To do like a special, you know, excursion? Go skydiving, kayaking?
They could, and we frequently have people through our clinic, just as I said, to see how we do it, and we coordinate that through our program coordinator. We have beautiful facilities. You will forget that you're in a medical clinic and think that you stumbled into a spa. But yeah, we do have a lot of people that come through.
Okay, well, you better make some time and accommodations for all of us. There's quite a bit of people on here that are going to be visiting you.
We'll be happy to see them.
Well, thank you so much. I don't think we have anything particular. It was more about comments, how there's some who've moved away from you and miss you. There's a lot of hearts and claps going, and questions about whether we are going to create this here in Michigan. Thank,
There is one question.
there is a question?
Are programs, who live near Seattle, are these programs available to us even if we get our care closer to home? Like, can they go there?
If they live in the state, can they go get care with you? Even if they're what, like a half hour away? Is that what you're saying?
Yeah, well, I'm reading the question.
Yeah, our catchment area is huge. We have people from most of North America that see us. I think our furthest south patient is from Panama, and we have probably a couple of dozen from Europe and 2 from Australia and several from Asia. But of course, most of them live within the Pacific Northwest. We have a large number of patients from Western Montana and Alaska that fly down here and see us. Seattle is sort of the main urban hub for those surrounding states, and we're traditionally the tertiary medical centers for those states. So we have, most of our patients live close in, but people live hours or hours by plane flight away from us, and they come here.
Okay, prepare for your visits. You're gonna have lots of visitors. Thank you so much for creating this program and improving people's life in your community and throughout the world who come to visit you and who you touch, and you're planting all these seeds. And I think the real message I took away was to be open to possibilities and don't take anything off of the plate.
Mm-hmm. That's right. It's amazing what people can do.
Thank you so much, Dr. Bone, and thank you to Betsy. You both were pillars at the beginning and conclusion of our program. As we conclude, I'd like you to watch Marcia's 1-minute video. It's wonderful. We're very lucky and fortunate to have Marcia in our community. She is an MS resilient, inspiring warrior and contributes so much locally to us and has taught me so much. And so without further ado, see Marcia, the MS inspirational, resilient warrior, Yoga Moves student and teacher and leader.
I held on to the flyer for a couple years. I'm like, I'm not doing that. Yoga's not for me. No, there's no way. But when I went into the yoga class, it was different. It was a warm welcome, and you feel so safe. All the teachers, if they need to lift your whole body up and place you on the mat, they will do it. I felt so like, oh, I can keep doing this because I feel so good. I have my family, I have my faith in God, and then I have my new family through MS. Yoga makes me feel relaxed, calm, grounded. Get into a community or support group. Do a form of exercise or yoga, whatever makes you feel good. It's not a death sentence, it's just a new way of life.
Thank you everyone for joining today. Once again, thank you to our amazing committee who helped plan this event. And that's Gina Beach, Lorraine Brantz, Marnie Sharon, Lindsay Dems, Kathy McRae, Leah Narens, Lori Olson, Beth Stone, and Lori Svensson. Thank you so much to our sponsors who are on the screen right now. Genentech, thank you so much for your continued support of Yoga Moves MS, your commitment to neurology, and particularly to MS patients and the science of MS. Gratitude to Biogen, Bristol Myers Squibb, Nanostata Horizon, Janssen, Novartis, Sanofi, TG Therapeutics, and the Mind in Our Backyard, Michigan Institute for Neurological Disorders. In conclusion, thank you so much for all being here today. And knowledge is power. the knowledge that we have now. Thank you so much to all our speakers for transferring this knowledge to us, for engaging in community, for even though we are far apart, we can feel each other's contributions and energy and quest for self-care, compassionate care to our own wellness and those around us. Yoga Moves MS is a community of individuals, resilient warriors brought together as we strengthen each other. Each of the stories that were shared here today and the knowledge weaves us together with this golden thread. Together we create the tapestry of life. Namaste. Thank you. Deep within my heart, this is the heart mudra. Thank you so much. Namaste to the whole Yoga Moves MS community.